we're dealing with mandates in future cases, but we don't know how to avoid that. In my practice, I noticed child at constant pain. You don't know what's the cause. Or you are pain. I find out later that can be development delay. They have found out that in my practice. And the 2% for you, at what age we can pick up muscular dystrophy? That anemia causes any water.
At what age can muscular dystrophy be picked up? Usually when the child will start walking, locomoting, that is the time when you will see motor delay. So any child this is the first age. If there is a delay in the gross motor milestone, any child with a motor delay, isolated motor delay, which will be obvious by the age of around 1 year when child should walk, that is the time when you
behavior problem. So increasing number of cases of behavior disturbance.
What is the cause? The cause. See, the incidence of autism has now, it's almost like 1 in 50 according to literature. There are few reasons why this has happened. The first and foremost reason is because these children were initially diagnosed as either speech delay or global developmental delay. We were not picking up that these kids are actually autistic. Now we have become enlightened to the idea that these children are not just speech delay or global delay, they are autistic. So that is one main reason why the incidence seems to be rising, because doctors are not picking them up earlier. They would earlier get recognized as speech delay or as global developmental delay. Now we are recognizing that they are autism and not the other two disorders. This is one main reason why the incidence appears to be rising. Screen time and reduced interaction with parents surely is the other reason. So increased amount of screen time in the early childhood period, peer group interaction is extremely important. When the parent-infant interaction has really come down, parents are working, child is glued to the screen for most hours of the day, we have seen these kids often develop autistic traits. So these are the two main reasons why it appears that autism is on the rise.
Any questions from audience?
Really, the screen time is a different cause. Is it being?
So it is like children with autism are of two types. One who have a genetic predisposition, the other who are as a result of psychosocial deprivation. So this second category, who have been deprived of interaction, in them it is seen that screen time surely has a role to play. In this group of children, if you reduce screen time and make one-to-one interaction with parents happen, these children have very good outcome. So we cannot say that this is the cause in children who has a child who has a genetic predisposition. If the child has a genetic predisposition, then in that case screen time may not be the important factor. But in the other group, a genetic predisposition does not exist. Psychosocial deprivation is the only cause. In this group, screen time is very important.
Again, you got to queries. That to refer the child, even though we are identifying children with problems. Just I want to share. In Tamil Nadu, I don't know how family. Tamil Nadu, almost each and even this test at a medical college. Each and every test at medical college at a district early intervention center is equipped with a physiotherapist, and some centers are with an occupational therapist, speech therapist, and the pediatrician, and as well as a medical officer is taking in charge of. In addition to that, this national mission, every block level, the is getting instruction. Exclusively, it consists of a male doctor and a female doctor for a block. They go over the field visits. They are supported by a pharmacist and staff nurses. Even such children are found in Anganwadi centers also, they identify the child and they bring it to the knowledge of the district early intervention center. They have got a special vehicle allotted for them so that they can pick up the child and bring it to the knowledge of the district early intervention center. And here in medical college, they got all specialists and they are really doing a good job. The district early intervention centers are doing a good job. In addition to that, the government of India has come out with a plan of setting up block early intervention center, PIC also, is also on the pipeline. But it is in coordination with the education department along with the schools also, they are going to implement it shortly, sir. So, if you have got any difficulty in referring this patient, if I can refer it to the nearby medical college hospital to attend the district early intervention center. As far as I think around 35 or 43 district early intervention centers in Tamil Nadu, and all of them, as far as my knowledge, are really doing a good job in early identification of the problems and trying to do the needful. Probably they may not be having some advanced outpatient and all, but basic identification and further referral and especially medical services, if they need any surgical correction and all also we are doing so. Thank you.
Thank you, sir. Thank you, ma'am. May I now request our chairperson, Dr. Murugan, sir, to felicitate our speaker, Dr. Erika Motte, for her talk. I now request Dr. Bhaskaran, sir, Senior Pediatrician and Past President of IAP, Puducherry Chapter, to felicitate our chairperson, Dr. Murugan.
Thank you, sir. We shall move on to the next session. Pediatric urology involves management of genital and urinary problems that occur in children of all ages, with a special emphasis on developmental problems. Now I call Dr. S. Kumarave, Professor of Pediatric Surgery, to come to the dais to speak on common genital urinary problems for the pediatrician.
Dr. Ilandarian, Pediatric Surgery from Bangalore, will share the session. Dr. Ilandarian, sir, is presenting running a pediatric surgical unit in Bangalore. He has innumerable number of presentations and publications to his credit. Apart from his academic achievements, he has innumerable number of non-academic activities, which include fitness, yoga teacher. Is interested in ornithology, wildlife photography, drawing, painting. We are very proud and to have you here today, and we are very happy to have this session chaired by you.
Thank you so much.
Sir,
I'd like to introduce Professor Kumarave here to the audience. He's Professor of Pediatric Surgery in JIPMER. He did his MBBS in 1994 at St. John's Medical College of Bangalore, MS Surgery at St. John's 1999, and MCH Pediatric Surgery 2002 ICH. His career highlights are Dr. Bishop Endowment Prize winner, Innovations Award winner for 2 years, member Multidisciplinary Robotic Committee, Vice President, JIPMER Scientific Committee, invited faculty for 39 Association of Minimal Access Surgeons of India skills course, trained in advanced pediatric robotic urological surgery, USA, postdoctoral teacher, guided more than 20 PCs, innovative surgeries like OMA's piggyback technique for IVC thrombus for children. These are his academic excellence, and we know Varavil sir has been a blessing for Pondicherry and JIPMER as a pediatric surgeon. Personally, as a good friend and a very approachable and down-to-earth surgeon with a lot of academic background. Sir, on to you, sir. Thank you.
Thank you for those kind words. At the outset, let me thank you all for inviting me to the inaugural session, CME session of the Pondicherry Academy of Pediatricians. Without further ado, let me go over to the next slide. Greetings from Jitmar. And urogenital problems, as you are all very aware, are very common in children. And they require an appropriate expert management. You will all accept this. And if it is not done, it might worsen the prognosis, or unnecessary interventions may be done where it is not necessary for transient problems, or they may even cause irreparable damage. So to avoid these things, we need to have an understanding of what is happening to the child at that point in time, and what interventions can be done, should be done, and how to evaluate this. Sorry. So I'll be covering all the basic standard genitourinary problems, and not something which is out of the way or unusually seen. Just 2 case capsules just to start off. A newborn child is referred with absent testis. Okay. Excuse this. So a newborn child on day 2 of life comes to us, or is seen by a pediatrician with absent testis, or a 2.5-year-old child is come to you with an absent testis. The two of them are managed slightly differently, even though both of them require an evaluation. So I am really sorry. So what are the things that we need to do? We need to examine this child. Everyone has examined the genitalia, but at some point we have lost the art of evaluating and palpating the testis, and have started to rely more on the sonologist to identify the testis for us. This is not really necessary, as in a born relaxed patient, you are experts at getting a rapport with the child more than the pediatric surgeon probably, and examining in this frog-leg position, milking the testis down from the abdomen, inguinal canal downwards, and seeing all these basic things will make sure that one can identify whether the testis is palpable or not palpable. Yeah, this also. So also a few other things need to be evaluated along with the testis. Let's not focus only on the scrotum and the testis, but also on the phallus. See whether there is an hypospadias, because this group of patients are likely to be managed slightly differently. In the case of the first child, a child which comes at 2 days of life, one can safely wait for up to 3 months, a little longer in cases of premature children, to see whether it descends. Previously, we used to say wait for 1 year for the testis to descend. However, it has been shown almost a decade back that those patients in whom in 1 year it has descended has actually descended by the first 3 months. And in the next 9 months, not many patients does the testis descend. It is also shown that the testicular degeneration starts by around 6 months to 1 year, and therefore completion of surgery before 1 year becomes essential. So what is the treatment? If it is palpable, most of the time we are able to do orchidopexy, and if it is not palpable, then we need to evaluate further. These basic things I'll just go over. Why do we require early orchidopexy? Reason, as I have mentioned, 1, preservation of spermatogenesis. 2nd is preservation of the leading function, that is testosterone production. Does this prevent or decrease the incidence of malignancy? Jury is still out. We need to remember that malignancy occurs in the 2nd, 3rd, 4th decade. So we need to see if the intervention of early orchiopexy, that is 6 months to 1 year, which we presently know, has gone on for about 3 decades before we can say it has come down. But early evidence from Scandinavian studies seem to show that there is a slight decrease in malignancy, but it has not been proven. Basic definitions I will leave. I'll just highlight one point, that a gliding testis is one. Okay, doesn't work. A gliding testis is one. This is the gliding testis is one where you are able to pull it down to the scrotum, but if you leave it, it goes back. This requires surgery, whereas a retractile testis is one which you can bring it down and leave it into the scrotum, and if the child is relaxed, it stays back into the scrotum. No intervention, either hormonal or surgical, is required for this group of patients, however anxious the parents may be. So this is a very old study. So basically, we decide on what to do with a testicular maledescent based on whether it is palpable or impalpable. Ultrasound has very little role in this particular management, how we go about it. Inguinal exploration is required for all patients who have got a palpable undescended testis, whereas laparoscopy, diagnostic laparoscopy, is required for all patients who have an impalpable testis. However, in patients who have not been adequately evaluated in the pre-operative period, that is, the child has always been very active or not cooperative, or the child is obese, then we always do on table under anesthesia palpation to make sure that it is not a palpable undescended testis which has been missed. And then if it is palpable on that, it goes for inguinal exploration. And if it is still impalpable, we do a laparoscopy. What do we actually see on laparoscopy? We identify whether the vase and vessels enter the deep ring. From inside, it is easier for us to identify rather than from outside. And from inside, we'll be able to identify this. I'll just show a couple of pictures just to make. This is a bilateral undescended testis, which is impalpable, and the other side is a right-sided undescended testis, which is impalpable. And this is what we would see in these patients. So here is the vessels. This is a right-sided one. Here is the vessel which is seen, and this is the vase which is going into the deep ring, and it has entered the deep ring. That means it is no longer within the abdominal cavity. At this point, we need to do an inguinal exploration. Laparoscopy ends here. In this case, we can see the vase. This is the vase deferens, which is going into a closed deep ring, but there is hardly any vessel seen. This is a case which most likely we will end up finding a nubbin or a testis which has already undergone atrophy. However, we usually explore and excise this nubbin. This is another option, another possibility that we find on laparoscopy, that there is a good sized testis, and along with the vessel, here's the vessel that is seen, and here's the vase, and this is in a low position very close to the deep ring. This can be operated and brought down as a single stage, and an orchidopexy can be done in a single stage. If the same testis was higher up, somewhere far away, 2-3 centimeters away from the deep ring, then we would go ahead and do a orchidopexy, which is of 2-stage technique. This is a single stage orchidopexy. One can see that the testis has come down here. Oh, this is not being seen here, is it? Sorry. And this doesn't work on a LED screen, so I don't think it's of much use. No, I'm using the cursor in the laptop here, but it's not working. That's it. I think they are putting it from there. You are doing it from there, so it won't. But it's fine. It won't work on a LED screen. So okay, you are able to see. Thank you. So here's the testis in a single stage orchidopexy. Maybe I'll just point out a couple of things in the previous slide. So this is the vase. White line is the vase here, and this is the closed ring. And this is the vase here, and the vessels are seen nicely. These are the testicular vessels which are going into an open ring. Probably the testis somewhere in the canal. Okay. Now this child has undergone bilateral orchidopexy in a single stage, and the testis is down there. This is the open surgery for a palpable undescended testis. The testis is brought down, and this is the kind of scar, and testis is down there, which is seen after surgery. Okay. Going to another group of problems again with the testis. A 9-year-old boy is brought with sudden onset left scrotal pain. A very common scenario. Most people see a few of these cases in a year. And what to do next? An acute scrotum is a very important thing that everyone has to refer as early as possible and not delay if we need to save the testis. And this is the message that I would like to. There's a lot of differential diagnosis, epididymoarthritis, idiopathic scrotal edema, and a lot of things, but no clinical examination can reliably differentiate between all these things from the acute scrotum if it is unilateral. If we have a scrotum like this, bilaterally swollen, probably the phallus is also shows, the prepuce also shows some swelling, and there is no pain, no tenderness, some itching is present, and idiopathic scrotal edema can be safely diagnosed here. If on the other hand there is an ulceration, there is some cellulitis, swelling, tenderness is present, again torsion testis may not really be high on the cards here. However, if you get a patient like this where there is pain, tenderness, some swelling is there, some redness is there, then we cannot reliably differentiate this from testicular torsion with the other things. Classically, it is said that patients may have all these features, unilateral testicular plane, etc. Try and go near a baby and try to lift the testis and see whether the pain decreases or something. It is not going to happen. You are not going to get any information out of it. The loss of cremasteric reflex has been shown. However, it has to be on the ipsilateral side rather than on bilateral cases. If the ipsilateral, it may indicate that there is torsion testis, but none of these are reliable. Ultrasound is difficult, and loss of testicular function or loss of testis is only 10% if the child comes within 6 hours of onset. However, it is less than 10% of children can have their testis saved if they come beyond 24 hours. So if we keep pushing the child, trying to get the ultrasound, a Doppler study from a good place and all this, then we are going to lose valuable time, and all this may lead to loss of the testis. If you can get it early within your own place. When I was in practice before I joined JIPMER, that's about 10 years back, I referred a child for ultrasound, which was just across where I was practicing. The person told them to come the next day morning. So they are busy. The sonologist is busy. It is just across my on busy street. But this is what will happen, and you will lose the patient. Parents don't know how serious the problem is. So losing the testis for ultrasound is not really worth it. And the onus is on us to convince them for the surgery. And since bell clapper deformity is bilateral, which is one of the predisposing factors for testicular torsion, one needs to do fixing on both sides if the testis is salvageable. So this child came on day 3 because of this furuncle. You can see here there was some redness. They thought all the testicular pain is also because of that, and they came to us on day 3, and the testis was lost. However, this particular child was in the hospital for something. It's perinatal. It's in the first 20 days of life, and there was bilateral. The pediatrician referred it. We took it up almost immediately, and the testis was able to be saved. At the end of the day of this particular one, testicular torsion can be present in any child with acute scrotum. And if the patient presents before 24 hours to you, then the chances of salvage is there. Refer immediately. If it is beyond 48 hours, the chances of salvage are very less. So you can take your sweet time, get the ultrasound, get everything, refer it to us. Anyway, most of the time the child's testis is going to go. Between 24 to 48, you'll have to have discretion, but less than 24 hours, refer to them as early, refer to the surgeon as early as possible. Next, I will leave the genitalia alone and come back to an antenatal hydronephrosis or hydronephrosis, a child who has presented to us with hydronephrosis. Ultrasound has become ubiquitous. The quality of the ultrasound, the antenatal ultrasound, is what is not so good. Everyone has now walks around with a antenatal ultrasound nowadays. but how much information we are able to get out of it is still questionable. Obstetric scans are quite commonly done, and one of the most common anomaly picked up is the hydronephrosis. Many of them are transient, they will disappear within the couple of ultrasounds in the antenatal period itself, but almost all of them will require at least one scan in the postnatal period. If the anteroposterior diameter, now scans are becoming more and more precise, and they are able to pick up things which are 2 millimeters, 3 millimeters, and they report all these things because they are also worried about Consumer Protection Act and other things. The onus is on us to identify which of these are significant and which of these are not significant. The anterior posterior diameter is usually less than 6 millimeters, then it should not be called hydronephrosis per se. In the 12 to 26 weeks, anything greater than 6 equal to 6 millimeters, and in the older, that is in the third trimester scan, anything greater than 10 millimeters has to be considered quite significant. If ureteric dilatation is noted, then it is definitely abnormal, because a normal ureter is unlikely to be seen on the ultrasound. Sex of the fetus is important, but we will not have that information until the child is born due to various reasons in our country. And any hydronephrosis with a ureteric or bladder abnormality or any hydronephrosis requires a postnatal ultrasound. This ultrasound should not be done on day 1 of life, because the GFR of the child in the first 2-3 days while the transition is occurring is very low, and therefore might not be adequate to fill the kidneys of the renal system. So even though hydronephrosis will develop a little later, there is not enough urine to distend all these organs, and therefore it might come back as normal or 7-8 millimeters. Wait for at least 3 days. 7 days is ideal, but 3 days at the time just before the child is discharged, get an ultrasound in these patients, and that is usually quite predictive of what the child is likely to have. If the patient has got an ultrasound which is abnormal between 3 to 7 days, start the child on chemoprophylaxis, wait for the child, repeat the ultrasound at around 6 weeks of age. 4 to 6 weeks is the second ultrasound, and at that point, if it is hydronephrosis, the management is slightly different. If it is hydroureteronephrosis or bilateral hydronephrosis, then an MCUG is required. Early MCUG in the neonatal period is also not very good, because if there is an infection which occurs because of the MCU and iatrogenic infection, the babies do not do really well. So the common causes, there are plenty of causes. These are the common causes: a PUG obstruction, a vesicoureteral reflux, a primary obstructive megaureter and posterior urethral valves. I'll just go through a couple of them in more detail. In the antenatal period, there is not much that needs to be done unless there is bilateral hydroureteronephrosis, oligohydramnios present. Otherwise, most of them can be followed up. There is no indication currently for either early delivery or for cesarean section or for termination in these patients of hydroureteronephrosis. I've done this already. So I'll come to a case capsule now. This child, this is the first pregnancy of non-consanguineous parents. The antenatal scans at 5 months was reported as normal. The 8-month scan, however, picked up a grade 3 unilateral hydronephrosis. A grade 3 SFU grade 3 would be equal to more than 10 to 15 mm of dilatation on the transverse pelvic diameter, along with thinning of the calyces, which means to say it is quite severe hydronephrosis. Normally, the kidneys will be like this, or just about able to be identified, but in hydronephrosis would be looking like this. This is also normal in the in the longitudinal section, and this is a hydronephrosis in the antenatal. Both these are antenatal. These are not of this child. This is just to show what it is. This child had a day 1 scan, which was reported normal, and parents were advised everything is fine, and they were left off. At this, the child further developed from month 1. Multiple episodes of fever, was treated with just antibiotics, mostly thought to be LRI or URI. Until 8 months, when somebody noticed that the child also has pyuria and an ultrasound was done showing hydronephrosis, and referred to the pediatric surgeon. At this point, a urine culture showed a culture positive urinary tract infection. How did we go about this? So this is the normal right kidney. This is the left kidney, which shows the gross hydronephrosis. You can see the huge calyces and the huge pelvis here. Transverse pelvic diameter was more than 5 centimeters, that is 50 mm. MCU was done after the culture was negative and the child was treated with antibiotics. The child did not have any reflux. In the presence of urinary tract culture positive urinary tract infection, even in unilateral hydronephrosis, MCU is safer to be done after cultures are negative. IVPs are not usually done, but in this case, I just wanted you to understand what gross hydronephrosis. This is how the normal kidney will be. You can see the calyces and the small pelvis going down to the ureter at the dependent part, and here you can see no ureter, and there is this entire blob is the pelvis. You can see the comparison between the normal side and the abnormal side. That was the size of the hydronephrosis, and this was on day 1, not seen on ultrasound. So it can be quite misleading the day 1 ultrasound. On the diuretic renogram, because there is no MCU shows no reflux and there is a dilatation, we want to know whether the function of the kidney, the function had come down to 29%, which is along with the significant obstruction. This is a normal EC scan or a DTPA scan, which shows it goes up and then rapidly comes down by around 8 minutes. More than half of the radionuclide has drained out. Whereas in this case, this is the patient's this one kidney, that is the right kidney, has come down normally, whereas the left kidney continues to rise up. That is, there is retention of radionuclide tracer in the kidney. So at the time of this child was taken up for a pyeloplasty, and this is open pyeloplasty. At the time, you can see that the huge pelvis, we are tapered, and then we have done the pyeloplasty. At the end of it, the pelvis is draining into the ureter. What happens to the child? This is the child in the first year. This is the scar of this one. I'm just showing the scar, and but growth and recovery is all good. Here's the pre-op, and this is the post-op. The pelvis has come down in size and the calyces have become near normal. Now, more and more we are going in for pyeloplasties, which are of minimal access, so that we not only give the same benefit to the child of a pyeloplasty with the same recovery, but less trauma to the child, less scars. And this is robotic, which we have started recently. We are not recently, about 2-3 years. And this is a child on table for a right-sided pyeloplasty. This is how it is draped, and this is the robot which is docked over the patient. Because the robot is so huge, the patient almost disappears underneath it. But the procedure is done with very good visualization. Here's the pelvis, here's the ureter. The obstruction is excised, and the normal ureter is sutured onto the. This is another child who had a very large pelvis, possibly like the child which we saw 5 centimeters, 8 centimeters, where the pelvis has to be tapered and a long anastomosis has to be done. With the robot, the suturing and the reconstruction becomes quite easy. And this is one. This is on the next day after such a major surgery. Child is quite comfortable with just paracetamol. No opioids, no other NSAIDs. The child is quite comfortable. This is one of the advantages of a minimal access surgery. What are the outcomes? The outcomes are as good as open surgery. Robotics or the minimal access also helps us to avoid major scars and perform the same procedure quite comfortably in obese, older children. And the scarring, this is the kind of scarring that we expect after a few months after the surgery. Okay, what are the pitfalls in the care of this child? This child underwent of this index case. Child had a cesarean section for the antenatal diagnosed hydronephrosis, which was not indicated. The child's day 1 scan did not pick up, so it was left alone. The child's fever was not evaluated appropriately, or at least a urine routine microscopy would have probably picked up these problems earlier and could have avoided. We do not know. The child's kidney might have been at 30% even from the beginning, but might not have had a poorer renal outcome. So, possibilities of abnormality. If we see a transverse pelvic diameter of about more than 20-25 mm, then 90 to 95% of these children require a surgical intervention. Whereas if it is less than 10 mm, hardly 3% will have a significant obstruction. So this is on transverse pelvic diameter alone, we will be able to evaluate what is to be done. I have gone through this previously. What is the timing of surgery? It is influenced by the renal function. It is influenced by whether there is symptoms of pain, infection, mass, and the surgery we do is dismembered pyeloplasty. I think I've done this. The next child that I would like to present, and I'll probably close there for features of time. For features for the time constraint. This 4-month-old was presented with a poor urinary stream. So is this phimosis or something else? Let's go through the child. This is a male child, third born of non-consanguineous parents. It was a full-term normal delivery. There was no antenatal scans done. There was no antenatal problems either. The parents have noticed a thin and poor stream of urine since birth. Occasionally, the child would even pass urine in drops. From 2 months onward, the child has been having crying and straining to pass urine. Parents specifically said there was no ballooning of prepuce, and the lower abdomen distension was seen by parents. This was how the child was passing urine when I saw the child after 2.5 months of age. And the child presented to the madam probably will remember this. Professor Nalini madam will probably remember the photographs later. This child came to us with fever, respiratory distress, poor feeding, and decreased urine output, and had consulted twice from 2 months of age and was diagnosed as phimosis and treated by stretching of the prepuce. There was no improvement and the child's condition worsened, and when it came to us, the child was severely dehydrated, had acidotic breathing, and bladder was palpable. The creatinine was 2.8 and 40 to 45 parcels in the urine with a pH of 7.14. The ultrasound showed grossly dilated kidneys, bilateral hydroureteronephrosis with a thickened bladder, and the culture grew E. coli and Pseudomonas. And we started the appropriate antibiotics, and the child improved. We had treated the hypertension with amlodipine, and we treated acidosis with bicarbonate, both intravenous followed by oral. This, and then the MCU was done once the culture was negative with a suspicion of posterior urethral valve. This is a normal MCU, just to show the contrast. This is a normal bladder, outline is smooth, and the posterior urethra is just slightly bigger than the anterior urethra. This is the posterior urethra. Contrast this with this child's MCU. This is the bladder, which is looking smaller than the whole posterior urethra here, and there's a very thin stream. And you can see that the ureter is also seen, and the vesicular reflux is present on the right side. So in this cases, the diagnosis is nothing but posterior urethral valve. We did a catheterization, and with the catheterization, once the creatinine came down, but the sepsis had come down controlled, but we are not happy to do a primary valve ablation, went ahead and did a vesicostomy for this child. And once the creatinine came down, the child was then taken up for valve ablation, circumcision, as it was a Muslim child. And child also had other problems of UDT, hernia, and other things which were also taken care of. This is the scar after the closure of the vesicostomy. This is the child at around 1.5 to 2 years of age, and this is the child came to me at 19 years of age, just about a couple of months back, and the child is doing very well. This is what I said, madam, probably identify. Okay. So children can do well if managed properly, but we could have, the current creatinine of this child is 0.73. So when we diagnose PUB, if the patient is uremic, acidotic, urosepsis, and sick, we catheterize the patient. And if there is improvement and the child becomes normal, we can go for primary valve ablation. And if the child does not improve, then we'll have to think of supravesical diversions. If the child improves, still not stable, then a vesicostomy is plant. You might think that this is a 20-year-old case. Trust me, I have in my ward posted for day after tomorrow for primary valve ablation, which has come almost exactly similar. Only difference is that time I was the primary person looking after this child because the child came to pediatric surgery. This time it is the pediatrician who is looking after, pediatric nephro is looking after the child, who has come about 4 weeks back, not 4 weeks, sorry, 2 weeks, about 15 days back, with at 4 months of age. They have corrected everything and referred it to me. So this happens even to this day, and we should not have this kind of the missed diagnosis possibly. Primary valve ablation, I'll just take probably another minute. Primary valve ablation is done with a cystoscope, and the valve is ablated. The C-arm is used here to identify, because on table I did the MCU for this child, but usually we get the MCU done prior itself before planning the surgery, and after the ablation, you can see that the urinary stream is near normal. Removal of the valve or the incision of the valve and getting a good stream is not the end point of posterior urethral valve management, because the problems have not only stayed with the posterior urethra, they have gone on to the bladder, ureter, and the kidney, and therefore they will require real long-term follow-up, like the one that I have shown, 18-19 years under us, and then afterwards handed off to the adult nephrologist. So by pathological phimosis is rare in infancy. It does not, phimosis has been blamed, that is that poor prepuce has been blamed for a lot of things before it gets cut and thrown away. But pathological phimosis is rare in infancy. Febrile culture post UTI should never be attributed to phimosis without evaluating other things. Poor stream since birth, febrile culture post UTI, and failure to thrive should be considered posterior urethral valves in males. With this, I will skip the other slides, which are just a few slides. Many thanks to my patients, their parents, without whom I will have nothing to talk about here. And many thanks to my residents, past and present, also for the excellent data collection that they do. Thank you one and all for the patience.
Thank you very much, sir, for amazing facts. We have actually had our how to go over. It was really enlightening, sir. Thank you. I request Dr. Aaron to speak.
Thank you, Dr. Potpourri. I especially love the last slide. The birth.
Thank you.
As we open up the stage for discussion, first I'd like to appreciate and congratulate IIT Pondicherry. I think I'm a small conversation, you can give a quick clap to IIT Pondicherry for entire PhD. Big thanks to all of us that we see. Our education is a senior friend. And of course, first, brilliant selection of speakers. First, Mangalarama Madam, I just love your presentation. It was more human than dog today. A lot of science with the human touch, and of course, Marvin sir, human with robotic arms. And the choice of topic, urological anomalies in children, because that is a very important topic. If you notice in the pediatric surgical OPD, 40% of pediatric surgical problems are urological problems. There's a specific reason for this, because urological problems, the evolutionary, if you look at it, urological system is from the ectoderm, endoderm, and mesoderm. Kidney is from the mesoderm, the ureter is from the endoderm, and the terminal ureter is ectoderm. So there's a play of all these layers, all these three layers are one place. And also, a lot of events happen. The testis comes down, the kidney affects the, and it's a small system where you have a lot of fluid going up and down, valves there. So a lot of anomalies are very common in urological system. So that is why urology is one of the pediatric urology is one of the very important subspecialties in pediatric surgery. Here, one point I would like to insist is pediatric urology is to be dealt with by pediatric surgeons. Okay. This is one thing which is commonly missed. Sometimes people think some problem with the kidney, the urologist has to manage. Not like that, because urologists deal with adult problems. Those are not congenital problems. Pediatric surgeons deal with all these evolutionary problems. So pediatric surgery is more about reconstruction and trying to form or try to save the kidney adult is about replacements and all those things. So any pediatric urological problems we dealt with by a pediatric surgeon. This one, I say I want to send across. If an infant has a bronchiolitis, we don't refer them to the chest physician. It is a primary pediatrician or the primary care physician or pediatrician or the neonatologist who takes care. So that is one important message because most of or all these pediatric urological problems are congenital in nature and they have been dealt with by a pediatric surgeon. And that is what Kumar said, how to intervene early, when to look at the antenatal ultrasounds and when to identify the high risk individuals who are having urological problems. So the topic is open for discussion. Anything you would like to ask?
It's not very fast, very good setup, sir. Especially at pediatric practice in peripheral area. Going to closest about 8 to 9 p.m. in the night, usually come across case of acute stroke. But there won't be any visit for ultrasound time. And it will be like a age to school and complaint of pain and vomiting, and they have waited for it, taken some drugs. And they are about to close it up. My question is whether is there any need for ultrasound examination? Proceed right away with exploration.
Thank you. Very, very nice question. I was hoping I would wanted to tell this on my own. So, the reason for us telling that most pediatric surgeons telling that you don't require an ultrasound is so that we do not, especially in our setup, is that we do not want the time to be delayed. Exploration is required for all acute scrotums. I just, if I have the time, Professor Ravi Kumar, everybody knows most of the. So, he is the director of the institute, of an institute, I will not mention it, and an administrative head higher than him, the administrative side, brings his child to him with acute scrotum. Within 3-4 hours, he advises surgery. This is told by him itself to our pediatric surgical forum. That's why I'm sharing it. The others suggested why not we do an ultrasound before we go ahead. And this is a big center. They got an ultrasound, found that there was increased blood flow. They said, what is this person telling? Surgery, got good blood supply, in fact, it increased, and they avoided surgery. 6 weeks later, the patient came back, the person brought it, sir, this is missing, what can we do now? Ultrasound in a baby for with Doppler is not an easy thing. Right? Even in big centers, it is not an easy thing. Trying to do that by a sonologist who is in the periphery, who doesn't see children regularly, is even worse. Okay. So the ultrasound does not really help in this group of patients. Ultrasound, we rely, pediatric surgeons rely on ultrasound much more than CT scan and MRIs and all that. But I myself am telling you that ultrasound for this procedure, for this is not really very reliable. And instead of that, we can go ahead with primary exploration. Beyond 24 hours, yes, primary exploration. Only thing is we have to counsel the parents that it is for the child's benefit and for the safety of the testes. I'm not telling that all of them will be testicular torsion. About 30% you might have negative this one. But the wash, doing the wash of the testes, closing the scrotum back and putting on antibiotics, they will recover completely. And it's a very short procedure. Anesthesia is safe in these days. And for this procedure, it is worth exploring them primarily without doing ultrasound, without wasting time. In JIPMER, if we convince the anesthetist, they will give the anesthesia for this procedure even without NPO status. Without NPO status, put in an NG tube, empty the stomach, take it up for anesthesia for scrotal exploration. We have been able to convince them. So it is worth, and if that kind of aggressive management is done, we will be able to save. Because it was told, I put up the statistics from the list. Within 6 hours, parents should not have decided to bring the patient to the hospital, where to the primary doctor. Forget coming into the theater within 6 hours. It doesn't happen in India. 24 hours is what they come, and around that time we are still able to save about 80%. But if it is beyond 48 hours, then I think it is very difficult to see.
instance of negative exploration.
That's all. Around in 10 patients, 2 to 3 patients have negative explanation. But that is something which I tell the parents beforehand, that even if it is tested, torsion testis is not there, we will give a wash, we'll make sure other things are okay, and then close it times. Recovery should be good. We explain it beforehand.
You do ask him to talk in the mic.
I understand in practice it is difficult trying to convince the parent for a surgery. I am sitting in a government setup with a lot of layers between me and this one. But this is one place where it is worth convincing the parents.
It's too difficult to differentiate whether it needs ultrasound, whether it needs some. So I would suggest it's like splitting hair, too difficult. I would suggest pass on the baton to the next person. Or at least write in the your notes refer to a pediatric surgeon, because that has a lot of medical implications as well. So pass it on to the surgeon. Sometimes we do design, sometimes we go for ultrasound, sometimes we have sort of clinical and as well as some evidence that we might need an imaging. But better send it off to the nearest pediatric surgeon. Yes, sir. Yes, sir. Those were days before ultrasound. Those were days when medical legal implications were not there. And when these facilities are available, and especially now, the transportation is good. That is one remarkable feature. And people are able to commute even from distant villages to good reference centers. So we have to give them that benefit of everything. Yes, sir. Yes, sir. Sometimes. So we have to refer the earliest possible. No question. You have a question? No. Is there for water?
Thank you, sir.
Okay. For patients who have who are stable, no infection.
Ask him to talk in the mic.
Is the procedure of choice. So we'll go ahead and do a primary valve. If the patient has got ongoing sepsis, then if you try primary valve ablation, the child can go into septicemia, because we are cutting those, incising those valves. We are creating raw surfaces through which the urine is going to come, that will contaminate and cause the septicemia. So if the patient is not stable, we will not try to do a primary valve ablation. But as more and more advanced antibiotics are available, we are able to control the sepsis. We are doing less and less of diversions. So vesicostomy is done very selective. Last 3 years, I would have done one vesicostomy, whereas we used to do a lot more vesicostomies previously. Yeah, that is because of advancement. But the principle is the same. You have to prevent sepsis. If you are sure that sepsis has been taken care of, child is fine, asbestos has been taken care of, then we go for primary valve ablation. As I told you, pediatricians, pediatric nephro has admitted one child. I'm going to do primary valve ablation day after tomorrow for that child. But the child is unstable, the child has got ongoing sepsis, we would still go ahead with diversion as one of the options. Diversion has not become an obsolete surgery as of now.
Thank you, sir. So that is the time, I think. We have got a signal from the back end. So we finish this wonderful session. Thank you so much. For this.
I now request that the Dharmaliнгam Senior Pediatrician, past president of IT Military Chapter, to felicitate our chairperson for the interview. We now have a small tea break for 10 minutes. I kindly request the audience to come back to the hall within 10 minutes. Thank you. The inaugural ceremony soon follows the tea break.
broken ஆயிடுச்சுனா
புரியுது புரியுது புரியுது. இது யாரோட? இவரு டாக்டர் குமார்
செக் பண்ணிங்க சார்.
இல்ல ஓகே அது ப்ராப்ளம்.
நேரம் ஆகுமா?
அவர் வந்து இது பண்ணுங்க.
அவர் பேசுறதுக்கு வந்து சார் நீங்க பேசுறது இந்த
மைக் வழியா போயிடுங்க. சொல்லியிருக்கேன் அவர் பேசும்போது நம்ம அப்படியே நீங்க லைவ்ல தான் ஸ்க்ரீன் போடும்போது அப்படியே போட்டுக்கலாம். ஆடியோ வந்து போட்டாச்சு இல்லையா? சரி அப்போ பிரச்சனை கிடையாது. நடுவில் வச்சேன்
Check, 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 one, check, check.
சந்திரகுமார் வணக்கம்.
ரத்தத்துல இருக்க உப்பு கடல்ல இருக்க உப்பு ஒரே அளவு தெரியுங்களா உங்களுக்கு? அந்த உப்பு லெவல இவ்வளவு சின்ன மார்ஜின்ல நம்ம கிட்னி கண்ட்ரோல் பண்ணும். அது மாத்திரம் இல்ல, நம்மளோட பாடியோட pH, நம்மளோட blood pressure.
சந்திரகுமார் வணக்கம்.
அந்த ரெண்டு சின்ன சிறுநீரகம் ரெகுலேட் பண்ணும். வருஷம் நம்மளால ஒரு ஆர்டிபிஷியல் சிறுநீரகம் இன்னும் தயாரிக்க முடியல. அது சிறுநீரகம்.
Check, 1, 2, 3, check. 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 Please check, 1, 2, 3, check.
ஏண்டா எப்போ இருக்கு ஆம்பிள் வை.
Check, 1, 2, 3, check. Check, 1, 2, 3, check. Please check, 1, 2, 3, check.
மாத்திரம் சார் மாத்திரம்
இதுல இது இப்போ ஏரோ இது வச்சுக்கலாமா
சார்?
இல்ல இல்ல சப்போஸ் ஹைலைட் பண்றதுக்கு
ஸ்லைட் சேஞ்ச் தரவா?
ஸ்லைட் சேஞ்ச் இதே பண்ணிக்கலாம் இல்லையா?
அதுல கூட
இல்ல இப்போ இன்கேஸ் நம்ம இது பண்றதா இருந்தா நான் என்ன கேட்கறேன்னா ஸ்லைட் இருக்குல்ல, ஒரு இடத்த பயன்படுத்தினா இது காமிச்சுக்கலாமா?
அதுல
முடியாதா?
அதனால தான் உங்க பிரசன்டேஷன் எங்க சார் இந்த ஒயிட்ல வர சார்? நீங்க பிரசன்டேஷன்
இப்போ இதுல யூஸ் பண்ண முடியாதா?
மவுஸ் அங்க வராது.
மவுஸ்ல வந்து நான் டச் பண்ண முடியாதா? முடியாதா?
ஸ்லைட் சேஞ்ச் இதேதான் சார். நீங்க அப்படியே இங்கே ப்ரொஜெக்ட் ஆகும்.
ஓகே, அது இது இருக்கா? ஸ்லைட் சேஞ்ச் இருக்கா?
இருக்கு சார்.
அது
PPT ஓபன் பண்றேன். White government
இது டைம் இருக்குதா? இது
Madam,
I request everyone to assemble back in the hall, please. May I request everyone to assemble back in the hall, please. We move on to the next session. Thank you.
Check. 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 Check.
So welcome back. Now we will start with the inaugural function. I request the dignitaries to kindly come and occupy the dais. Dr. Amish Officer, Dr. Anand Sindhu, Dr. Rajendra, Chidambaram, Nalini, Professor Nalini, Mahadevan sir, Dr. Ravichandran, Dr. Shanmuganandam, Dr. Tirumurugan, Dr. Johnson Reddy, and Dr. Narayanan. Kindly occupy the dais, please. I request everyone to come forward, come and occupy the front seats. Front seats are looking so empty, please. Kindly cooperate. The hall looks so empty in the front. Please come and occupy the front seats. Thanks, Siddhi. Now I request everyone to rise up for the prayer song.
request the Secretary of IAP TNSC, the Dragon sir, to hand over the presidential call. I now request the President of IAP Potpourri chapter, Dr. Ravichandran sir, to give the welcome address.
Good morning, everyone. Hello. Right. Good morning, everyone. Warm welcome to everyone to Pondicherry. This is a great day for us. The formation of the IAP Pondicherry branch and the inaugural ceremony. I welcome IAP TNSC President Dr. Ramesh Babu, IAP Secretary TNSC Dr. Rajendran, President-elect Dr. Suresh Balan, our beloved past President Aram Sendil, and the doyens of pediatrics, Professor Mahadevan, Professor Nalini, Madam Chidambaram, and not to leave out senior pediatricians from Kadalur, Vilupuram, and Pondicherry who have traveled all the way to honor this occasion. And my dear friends and budding PGs. The formation of the Pondicherry branch was a necessity. Tamil solnonna Kalathin Kattayam. Not that we wanted to break away from the parent branch, but mainly due to auditing and financial issues, which were keep on occurring year after year. We want to make it very smooth. So that is the aim in which we started out. And I assure all of you that we will continue to function hand in hand with Vilupuram and Kadalur branch as ever. There is no hard feelings. We don't feel we are estranged from them. Not at all the case. It is purely a technical thing, which I want to highlight at this point. At this point, I also want to make a place on record the great success of Puduvai Pedicon 2021. It was really a remarkable event. So many dilemmas were there before the conference, especially the COVID pandemic. With all that, the great team, Dr. Thirumurugan Saran, Dr. Shanmuganandan, Dr. Elamaran, Dr. Rati Sharmila, Dr. Arul Kumaran, and so many PGs, everybody made it a very grand success. The memories are always green in my heart. And before concluding, I have one small request. Many of our pediatricians have not enrolled as members of IAP. As you all know, unity is strength. The more our numbers, the more we can raise our voice as a united force. So I sincerely request all of you who are not members to enroll as members. With these few words, I have great pleasure in once again welcoming you on this auspicious day. Thank you. Welcome you all.
Thank you, sir. The hall is already bright with wisdom and knowledge. I request the dignitaries to kindly light the Puthuvilakku and start the ceremony. Ramesh Babu, sir. Ramesh Babu, sir. Arvind sir. Dr. Rajendran. Mahadevan sir. sir. It was a beautiful moment. I request all the dignitaries to kindly offer the banners.
Now it's time to felicitate. I now call upon Dr. Aaron, President of IAPTSC 2020, to felicitate the guest.
அகர முதல எழுத்தெல்லாம் ஆதி பகவான் முதற்றே உலகு. எங்கள் வாழ்வும் எங்கள் வளமும் அங்காத தமிழ் என்று சங்கிய முழங்கு. இனிய தொடக்க நாள் நிகழ்ச்சி இன்று. இந்திய குழந்தை மருத்துவ சங்கம் புதுச்சேரி மாவட்ட கிளை அல்லது மாநில கிளை என்று சொல்லலாம். அதை இன்று அருமையாக நமது தலைவர், மாநில தலைவர் திரு ரமேஷ் பாபு அவர்களும், செயலாளர் திரு ராஜேந்திரன் அவர்களும், 3 பெரும் இந்த புதுச்சேரியில் மக்களுக்காக பெரும்பாலும் உழைத்த மூவர், மருத்துவர் சிதம்பரம் அம்மையார், மருத்துவர் நளினி மற்றும் பேராசிரியர் மகாதேவன் அவர்களும், இந்த புதுச்சேரி மாநில இந்த ஆண்டு தலைவர் திரு ரவிச்சந்திரன் அவர்களும், சென்ற ஆண்டு தலைவர் திரு சண்முகானந்தன் அவர்களும் இந்த நிகழ்வுக்கு பெரும் துணையாற்றும் துணை தலைவர் திருமுருகன் அவர்களுக்கும், இந்த நிகழ்விலே அவருடன் இணைந்து 5 ஆண்டு செயலாளராக பொறுப்பேற்கும் ஜான்சன் ரெட்டி அவர்களுக்கும் மற்றும் பொருளாளர் வினோத்குமார் அவர்களுக்கும் ஆக இந்த குழு இன்றைக்கு பொறுப்பேற்க உள்ளது. இப்படிப்பட்ட ஒரு அருமையான நிகழ்விற்கு என்னை இங்கே வர வைத்ததற்கு உண்மையிலே நன்றியும் பாராட்டுதல்களை தெரிவித்துக் கொள்கிறேன். 2021 டிசம்பர் புதுவை மருத்துவ மாநில மாநாடு, புதுவை பெடிகான், அந்த நிகழ்ச்சியை உண்மையிலே எங்களை இந்த அளவுக்கு ஒன்றாக இணைத்து தமிழகத்திலிருந்து தமிழகம் புதுச்சேரியிலிருந்து கிட்டத்தட்ட 800 இருந்து 850 பேர் குழந்தை நல மருத்துவர்கள் சிறப்பாக அந்த கோவிட் கட்டாயத்தின்லையும் வந்திருந்து அந்த நிகழ்வை சிறப்பித்தார்கள். அவர்களுக்கு பாராட்டுதல்கள். எங்களுக்கு அவர்களுக்கு எங்களால் முடிந்த விருந்தோம்பலை செய்தோம் என்ற ஒரு நிறைவு எங்களுக்கு எப்பவுமே இருந்தது. அதோடு மாநில பொறுப்பாளர்களும் மருத்துவர் இஸ்மாயில், மருத்துவர் ராஜேந்திரன் தலைமையில் இருந்த அந்த குழு எங்களுக்கு மிகவும் சிறப்பாக ஒத்துழைப்பு கொடுத்தது. அதற்கு இந்த சமயத்திலே நன்றியை தெரிவித்துக் கொள்கிறேன். ஆக இதற்கு இளைஞர் பட்டாளம் எங்களுக்கு கூட இருந்து உதவி செய்தது. அதுல நான் அந்த அத்தனை பேரையும் நான் சொல்லணும். அப்படிப்பட்டவர்கள் எல்லாருமே எங்களோடு இணைந்து பணியாற்றினார். அவர்களை நான் இந்த சமயத்திலே நினைவு கூறுகிறேன். அவர்கள் எல்லாம் சிறந்த பணியாற்றுவதால் நாம் அந்த நிகழ்வை சிறப்பாக நடத்த முடியும். ஆக இன்றைய தொடக்க நிகழ்ச்சி அப்படிங்கிறது வரும்போது, இந்த கிளை விழுப்புரம் புதுச்சேரி என்று இருந்தது. இப்போது புதுச்சேரி கிளையாக இப்போது அவர் சொன்ன மாதிரி தலைவர் திரு ரவிச்சந்திரன் சொன்ன மாதிரி இது காலத்தின் கட்டாயம். இது புதிய நிகழ்வு. இந்த புதிய நிகழ்வை நாம் ஏற்றுக்கொண்டு முதல்ல 2 மாவட்ட கிளைகள் ஒன்று சேர்ந்து செய்து கொண்டிருந்தோம். விழுப்புரம், புதுச்சேரி, கடலூர் சேர்ந்து பண்ணோம். இனிமே விழுப்புரம், புதுச்சேரி, கடலூர் 3 சேர்ந்து நிகழ்ச்சிகளை செய்வோம் என்று இந்த நேரத்திலே நாங்கள் கூறிக்கொண்டு, எங்களுடைய ஒத்துழைப்பு என்றும் உங்களுக்கு உண்டு என்பதை சொல்லிக்கொண்டு, இந்த நேரத்திலே 2 செய்திகள் தான். இந்த நிகழ்வு இன்று இந்த அளவிலே, சிறிய அளவிலே ஆரம்பிக்கிறது. இந்த மழை துளி மலை மேல் விழுந்து சிறு சிறு ஓடைகளாகி அருவியாக கீழே விழுந்து ஆறாக பெருகட்டும் என்று இந்த சமயத்திலே புதுச்சேரி கிளையை நன்றாக வாழ்த்துவோம். அவர்கள் சிறப்பாக செயல்படுங்கள். இளைஞர்கள் ஒன்று சேருங்கள். இளைஞர்கள் இவருக்கு, இந்த மூத்தவர்களுக்கு துணை நில்லுங்கள் என்று இந்த சமயத்திலே கேட்டுக்கொள்கிறேன். டீம் எஃபர்ட் இஸ் தி கீ. டுகெதர் எவ்ரிஒன் அச்சீவ்ஸ் மோர். இதை என்னைக்குமே நாம விட்டுறக்கூடாது. இது நாம் இந்த குழு வந்து இந்த குழு மனப்பான்மை அல்லது குழு முயற்சி அல்லது குழு நம்ம எல்லாரும் ஒன்னா சேர்ந்தோம்னா ஒன்று கூடித்தான் தேர் இழுக்க முடியும். அப்படி ஒன்று கூடி ஐஏபி தேரை இழுப்போம் என்ற இந்த சமயத்திலே உங்கள் அனைவரையும் வாழ்த்தி வாய்ப்புக்கு நன்றி கூறி நிறைவு செய்கிறேன்.
Thank you, sir. I now request Dr. Nagendran sir, Secretary of IAP TNSC, to present the gathering.
Respected our President, Dr. Ramesh Babu, and President 2020, Dr. Aram Senthil, our State AAA, Dr. Tirumurugan Sarani, and patrons, Dr. Chidambaram Madam, Dr. Mahadevan, Dr. Vishnupat, Dr. Srinivasan sir. So all dignitaries, Dr. Ramesh from Chidambaram, the new branch, the chair branch, President Dr. Ravichandran and Dr. N. Sanmuganathan, this is President 2021, and President-elect Dr. Narayan, and Secretary Dr. Johnson Reddy, Vice President Dr. Tirumurugan Sarani, President Dr. Vinod Kumar, and all faculties as well as delegates from all over Puducherry. So it gives great pleasure and privilege to be here as Secretary IAP TNSC. From here, I want to tell two things. One is Puduvai Pedican. It was in a critical situation. They conducted very well, and really from bottom of my heart, I will appreciate the team who has conducted Puduvai Pedican very successfully and very neatly, and also they contributed significant amount to state IAP for purchase our own IAP plot at Egmore, and really thankful to Dr. Aram Senthil sir, Dr. Namachivan sir, Madam Chidambaram Madam, and my brother Dr. Tirumurugan Sarani, and all other important personalities, and they helped us a lot to make this conference successful. And really happy that they started a new branch. As Dr. Ravichandran said, administrative purpose, the Puducherry branch is there, and I think we can coordinate always whenever necessary. More than that, past 2 or 3 years from the contribution from the Kadalur, Pondicherry, and Viluppuram to the state IAP is enormous. I can really appreciate because our President Dr. Aram Senthil has changed a lot of scenarios in IAP TNSC, and he has actually helped me and guided me come to this level. I really thank Dr. Aram Senthil sir for this opportunity he has given me as a secretary. And another one is important thing is second personality is என்னுடைய உடன்பிறவ தம்பி டாக்டர் திருமுருகன் சரணி has helped me a lot to come this SS Joint Secretary now AAA to making all the program success. I wish he has to be a next General Secretary of Honorary Secretary of IAP TNSC, and hope I think he will be a next Secretary, and wish all the best also for him. And so I am on behalf of IAP TNSC, I thank and appreciate all the dignitaries, respected professors, to help us to make these branches. I said 20th branch, this is from Tamil Nadu, and will support from Tamil Nadu aspect, will support always Puducherry branch, and I thank one and all.
Thank you, sir. Now I call upon Dr. Ramesh Babu sir, President of IAP TNSC, to give the presidential address.
Thank you, sir, for the invite. Respected Secretary of IAP Tamil Nadu State Charter, Dr. Rajendran sir. Respected President 2020 of IAP TNSC and present Central IAP EB member, Dr. Aram Chandil sir, respected office bearers of IAP TNSC, respected Central IAP EB members and state EB members, and respected President of the Pondicherry branch, Dr. Ravichandar sir, respected President 2021 of Pondicherry, Viluppuram Pondicherry chapter, Dr. Shanmuganathan, respected Secretary of Pondicherry, Dr. Johnson Reddy, respected Treasurer, Dr. Vinod Kumar, respected President-elect, Dr. Narayanan Parameshwaran, and respected Vice President of Pondicherry branch, as well as the AAA of IAP TNSC, as well as one of the EB members of IAP Tamil Nadu State Chapter, Dr. Tirumurugan, was the main person behind all these scenes. It's a pleasurable moment for me. This is the third new branch I am inaugurating after taking over as president. First one was at Tiruvannamalai in January, and second one was at Chengalpattu during May. Now it is Pondicherry branch. I wish the Pondicherry branch of IAP all the success in the future. One thing unique what I found in this Pondicherry branch is that institution of award, mainly NSVMC award by a district branch, by honoring the senior persons and legends who belong to that branch. Professor Nandini Madam, Professor Srinivasan sir, Professor Vishnu Bhatt sir, and Professor Mahadevan sir, and Dr. Chidambaram Madam. I don't think so far any district branch set up an award in the name of their area people who are the doyens of pediatrics and who have done a lot of work towards the welfare of the children as well as for the pediatric fraternity. First of all, I should appreciate for the team and the entire team as well as Tirumurugan for instituting this idea and have made it a success. And they have told that this award will be carried over the upcoming years, not as a single one, so that they have developed a corpus fund for the sustainability of the event. And apart from that, before the installation of the branch itself, Tirumurugan sir has successfully completed the registration of the branch and acquiring of the PAN and all the legal formalities, so that it will be very much easier for the upcoming office bearers as well as the existing office bearers to have a hassle-free conduction and maintenance of the branch activities. So really, it's a wonderful event, sir, and I appreciate all the district office bearers as well as the EB members, namely Dr. Arul Kumaran, Dr. Dandabani, Dr. Peter Prasad, Dr. Sriram, Joint Secretary Dr. Deepan, AAA of the branch Dr. Anuradha, for their hard work. I have failed to mention few of the names who are behind the formation of this branch and for the success of this branch activities. Please forgive me. If so, my best wishes for all of the members of the branch to carry out the branch activities in a successful manner. As President Dr. Ravichandar pointed out, the success of the branch lies in the strength of its branch. Few days ago, I asked our Aram Chandil sir to get the list from Central IAP to know about the membership strength of our state, and also we got the membership list of Pondicherry. What I am saying is as per the latest list available from Central IAP, for Pondicherry alone, Central IAP list shows a total of 143 members, out of which 99 are life members and 44 members are associate life members. I appeal to all of you to improve your membership strength, so that there are two possibilities. One, you have to identify and enroll the pediatricians who are not yet become AAP members. They may be seniors too, fresh graduates, please motivate them and enroll them. Don't consider membership drive as a time-bound event. Every day is a day for including a new membership. Suppose throughout the state, if you are able to enroll one member per day in our state, at the end of the year, we would have enrolled 365 members. One more thing is, presently, I think we have been carrying out the membership drive for the past 1 month, and today is the last day. We had fixed a target of 3,250 live members, because if you would have enrolled 3,250 members as on this day, we would have got one more central IAP EB membership for our state. That means both TN and Pondicherry combined. Unfortunately, I don't say unfortunately, in spite of our hard efforts, as on date, we are lagging behind another 30 or 40 members. Presently, our membership strength will be around, life member strength will be around 3,200. Suppose if we have enrolled another 50 members in this before July 31st, we are having a central IAP membership strength of 4 as of now. In the upcoming elections in October, you will be able to have one more EEB member, central EEB member, who will be represented from our state. But I am sure that before the end of this year, definitely we will reach this target of we will go beyond the target of 3,250. But what I am insisting you to do is, many medical colleges are there in Pondicherry. Many postgraduates are joining. At the time of joining itself, please ask them to become a member of IAP Tamil Nadu State Chapter. NMC has made it clear that every postgraduate should present at least one research article and present at least one poster in a state or a national conference. It is essential for appearing for the AMD postgraduate examination or the DMD examination. So, not only for the sake of that thing, the DIAP website is mostly underutilized by all the members. There are a lot of things. Many of our pediatricians or members are not visiting the central IAP website. For the students and for the postgraduates, a lot of learning and resource materials. Needless to say that our dynamic secretary, Dr. Rajendran, is carrying out on every Saturdays, alternate Saturdays, postgraduate and undergraduate teaching program for the benefit of the postgraduate and undergraduates. Now it is going on exclusively for postgraduates on every Saturdays. Eminent faculties, resource persons of all pediatric subspecialties are conducting that clinical case presentation session for the benefit of the postgraduates. Those resource persons will be the examiners for those postgraduates. I am learning a lot of things while listening to those sessions. So please also encourage your postgraduates to become members to get the benefits of IAP, as well as so that they can learn for their study period also. The short note, I once again appreciate the efforts of office bearers as well as the members of Pondicherry branch, and I wish them all success in their events in the upcoming days. Thank you for that.
Thank you, sir, for such a motivational speech. Now it's another beautiful moment. The IAP branch, Pondicherry branch, is honored to honor the dignitaries on the stage. I request the President Dr. Ravichandran to honor Dr. Ramesh Babu. Request our Vice President Dr. Tirumurugan to honor Dr. Rajendran. Thank you, sir. I request our secretary, Dr. Johnson Reddy, to honor the parents and the Now I request our treasurer, Dr. Vinod Kumar, to honor Chidambaram ma'am. Thank you. I request Dr. Chandravanandam to honor the Nalini ma'am. I request Dr. Johnson Reddy to honor Professor Mukha Devan. I request Tirunelveli sir to honor President Dr. Ravichandran. Thank you, sir. I call upon Dr. Vinod Kumar to honor our ex-president Dr. Chandravanandam. Thank you, sir. I request Dr. Vinod Kumar to honor our secretary Dr. Johnson Reddy. I request our president Dr. Ravichandran to honor Tirunelveli.
With the permission of the State President of Ramesh Babu, I would like to give the Presidential Appreciation Award during my tenure as a President to Dr. Rajendran, Secretary, for his wonderful contribution to the postgraduate and undergraduate clinical coordinator. Dr. Ramesh, Professor, RMCH, retired professor, will do this honor to him.
It's time to honor the stalwarts of our religion. May now request our President, IAP Puducherry Chapter, Dr. Ravichandran sir, to honor the stalwarts of our religion. I now call upon Dr. Murugesan sir, Senior Pediatrician from Kolidam, to come forward and have the felicitation from our President. Dr. Ramesh sir from Chidambaram. Dr. Dharmalingam sir, past President of IAP, Puducherry Chapter. Dr. Bhaskaran sir, past President of IAP Puducherry Chapter, Senior Pediatrician. Dr. Meena Shah ma'am, okay, from Puducherry, Senior Pediatrician from Puducherry. Dr. Meena Shah ma'am. Dr. Aruna Bain, Senior Pediatrician from Puducherry. Dr. Rajiv Soni, current HOD of the Rajiv Gandhi Medical College, Women's Children's Hospital. Dr. Durai Sami, Senior Pediatrician from Puducherry. Dr. Anuradha ma'am. Senior Pediatrician from Rajiv Gandhi Children's Hospital. Dr. Bharat Kumar from HOD, Department of Pediatrics, Rajiv Gandhi Medical College.
Dr. Adil Kumaran, Professor, Medical College. Somebody who works from the back and still never the real backbone in the success of the quality of our academic sessions of Puducherry. So big ovation for Dr. Adil, please. And Dr. Chitra, pediatrician from children hospital. இதெல்லாம் வந்து கேட்ட உதவி கேட்டா நிச்சயமா அவங்க ரெண்டே சப்போர்ட் பண்றாங்க உள்ள ஒருத்தவங்க யாருமே சொல்ல மாட்டாங்க. ஸோ அது ரொம்ப சந்தோஷம். தேங்க்யூ.
All of us. Now it's time to honor the dynamic person at the team. Without whom this mission would not have been possible. Now all of us know that from tomorrow we are going to celebrate World Breastfeeding Week. So I request our president to release the pamphlet regarding Breastfeeding Week. I request our secretary to kindly receive it.
Pediatric branch starting the new note of celebrating the Wallace Day, followed by inauguration, followed by election of World Breastfeeding Week. Usually, when I was an office bearer of Dharmapuri branch, I used to compete with the Kannur branch and Nakarpur branch because those branches were at the time belonged to the same category for the awards. And we were also successful, but I came, our branch was in the 25, less than 25 members category, and Vellore and Kannur were in the 25 to 50 members category. But now, Pandi is in the 100 members category, and Kannur as well as Nagar are also the same category. I wish Pondicherry branch to celebrate all the IAP days for the benefit of the children, so that the benefit of all the days goes to the community and for the children. And I also wish them to get more IAP TNSC awards as well as Central IAP awards. Thank you.
Sorry, another important member of our team has just got missed. Dr. Vinod, our treasurer, Kivana, our class. Vinod,
I now call upon Dr. Tirupati sir to introduce the concept of NSPMC award to the public.
Okay, good morning. It's in the recent past, I was just thinking about my teachers. I mean, I've always been thinking, with me getting older and my teachers also getting older, what I realize is some of them are kind of slowly disappearing from the memory of a lot of people. And how to make them, I mean, everybody remember them. I think I was very blessed because I had the opportunity to study in JIPMA under real stalwarts. அப்படின்னு எடுத்துக்கிட்டோம்னா இந்த 5 பேர் 4 பேர் உண்மையிலே வந்து அவங்கலாம் வந்து குரு, அதாவது மாதா பிதா குரு, அதாவது அந்த காலத்து குரு போல. இது இவங்களுக்கு நான் வந்து சோப்பு போடுறதுக்காக சொல்லல, சீரியஸாவே. Some of the things actually when we get older, அந்த வயசுல சின்ன வயசுல வந்து படிக்கும்போது இவங்க பண்ண சில விஷயங்கள் கோபமா வரும், அவங்களுக்கு மனசுக்குள்ள திட்டி இருக்கிறேன், சண்டை போட்டிருக்கேன். I'm known for having a short temper.
But as I get older, I realized what they meant and how lucky we were. I mean, JIPMER had 4 great professors, starting with Nalini Madam, thesis guide. I'll tell you, actually, Nalini Madam வந்து எப்படின்னா ஒரு தாயை போல. எங்களுக்கு இருக்காங்களோ இல்லையா பேஷண்ட்ஸ்க்கு ஏதாவது ஒண்ணுன்னா பேஷண்ட் வந்து போய் நேரா ரூம் முன்னாடி நிற்பாங்க. பேஷண்ட் மேடம் வந்து என்ன இப்படிலாம் பண்ணிட்டீங்கன்னு சொல்லுவாங்க. அப்பா இப்ப ரொம்ப கோவம் வரும், கஷ்டமா இருக்கும். ஆனா அதோட இம்பாக்ட் எப்ப எனக்கு தெரிஞ்சது when I went to UK. That's it. Because I don't think Indian doctors learn the art of being not art, and the feeling of empathy and sympathy என்பது நமக்கு சுத்தமா கிடையாது. அதுவும் particularly when you work in an institute with too much patient load, we stop being sensitive to patient feelings. Only when I went to UK, I realized how important it is actually. It's a visionary thought. நான் சொல்றது வந்து 25 years back, 1997, 98 when nobody talked about, no textbook talked about sympathy or empathy, at least Indian textbooks. Madam was the one who was the, என்ன சொல்றது, அது அம்மா அப்படின்னா அது அவங்கதான். அந்த விதத்துல வந்து I'm very much blessed actually to have Madam as my guide. This is a teacher and guide. Next வந்து Professor Srinivasan sir irukar. Actually he is going to talk to us on live Zoom la irukar, so we'll be able to talk to him also. He is going to just talk to us. That Srinivasan sir எப்படினா he was probably the blessed clinician I ever come across in my life. Somebody that is with no disrespect to any of the big stalwarts here. Somebody was so good. அதாவது சொல்லி கொடுக்கறதுல அவ்வளவு ஒரு பொறுமை. அது particularly as an undergraduate, post graduate கூட கொஞ்சம் கம்மியா சொல்லி கொடுத்தாரு, பட் undergraduate நிறைய சொல்லி கொடுத்தாரு அவரு. So somebody who did a great job. And third வந்து பாத்தீங்கன்னா மகாதேவன் சார், அந்த ரிசர்ச், அந்த கிரிட்டிக்கல் அனலிட்டிக்கல் திங்கிங், பேஷன்ஸ் வந்து அப்சர்வேஷன், அதாவது again same thing. அதாவது லாட் ஆஃப் நம்ம எப்ப அதாவது வெளியில போனாதான் உதப்பட்டாதான் வந்து புத்தி வரும் நமக்குலாம். அட்லீஸ்ட் எனக்கு அப்படிதான் வந்துச்சு, மற்றவங்களை பத்தி எனக்கு தெரியாது. So when I went to UK, I realized a lot of things actually which were being told by the senior people, which never I never realized it as a postgraduate, and only when வெளியில போய் அவங்களோட அருமையை தெரிஞ்சுக்க வேண்டியதாச்சு. By then I am no longer in JIPMER. So அந்த பேஷண்ட்டை பார்த்து அந்த கிரிட்டிக்கல் அனாலிசிஸ் சார் வந்து எனக்கு இன்னும் ஞாபகம் இருக்கு. அடுத்த நாள் காலைல ரவுண்ட்ஸ் முடிச்சுட்டு வருவார். Patient வந்து you should not just know only about the details of the patient. You should know about each and every investigation. Investigation இல்லனா வந்து கடுப்பாயிடுவார், சம கடுப்பாவார். So but I realized it important not then. It's only because he said you have to look at the child as a whole and try to analyze and then try to come up with a diagnosis and not just look at what is obvious. So and he really supported in the research for a lot of us, actually not just me alone. So everybody, அதாவது அடுத்து வந்து பட் சார் அந்த கரெக்டா 8 மணி அப்படின்னா 8 மணிக்கு இருக்கிறாருன்னா அதுக்கு வந்து அவர் வந்து நிக்கிறாருன்னா 8 மணிக்கு காலைல அர்த்தம். அதாவது பங்க்சுவலா வேலையை ப்ராப்பரா மெத்தடிக்கலா பண்றது. So great people with great individual areas of expertise and yet over a period of time, இன்னைக்கு இருக்கிற பிஜிஸ்ல கேட்டோம்னு வச்சுக்கோங்க, ஜிப்பர்ல I walk into, not many people will even know our நடமாடும் தெய்வங்கள். So honestly I felt, and the last but not the least, Dr. Chidambaram, actually Chidambaram madam கூட எனக்கு lot of interaction கிடையாது. I mean professional case பத்தி இருக்கணும் till I got into Puduvai Pedicon, and then I realized working with her, no, I realized how much she has done during a stay, I mean during a period in GH, and even after that. அதாவது பிரைவேட் பிராக்டிஸ்ல இருந்து நியாயமா நேர்மையா ஒரு கொள்கையோட பிராக்டிஸ் பண்றது வந்து ரொம்ப ரொம்ப கஷ்டம். இன்னைக்கும் அவங்களுக்கு வந்து 78 வயசு ஆகுது, இன்னைக்கும் அந்த சின்சியாரிட்டியோட பண்றதுன்னா. So that is why I thought, why not we come up with something which will kind of make sure that everybody remembers them. And அதனாலதான் வந்து அந்த NSVMC award சொல்லிட்டு பிளான் பண்ணது. This award will be there every year. It has been அதாவது totally transparent. ஸ்கோர் கார்ட்லாம் எல்லாம் பாத்தீங்க, அது மாதிரி தான் யார் யார் கிடைக்கிறது பண்றோம். I'm very much actually the input for the scorecard came from Madam Mahadevan sir, எல்லாருமே. So it's not just one person deciding. So I want this award to become something as great as any ஒரு BC Roy award இல்ல அந்த மாதிரி. இதுவரை ஒரு சின்ன ஒரு ஊருக்குள்ள இருந்து வரதா இருக்கலாம், ஆனா it should, அதாவது வாங்குறதுக்குன்னா ஒரு மதிப்பு. ஏன்னா this is named in some of the really best pediatricians in India. See, நம்ம ப்ராப்ளம் என்ன தெரியுங்களா, சவுத்ல இருக்கும் பொழுது lot of people don't recognize us. உண்மை அதுதான். I'm sure நான் இது முன்னாடியே சொல்லியிருக்கேன், and I have no qualms in saying this. If each and every one of them were in north, by now they would be celebrated so much. But it doesn't happen. It does not happen because we are in south. Okay, let's not get into the politics of it. But what I'm just saying is, it's unfortunate that they landed in south, but it's our fortune that they were here. They taught so many of us. அவ்வளவு பேரை சொல்லி கொடுத்து அவ்வளவு பீடியாட்ரிஷியன் உருவாக்கி எத்தனை குழந்தைங்களை அந்த பீடியாட்ரிஷியன் மூலம் காப்பாத்திருப்பாங்கன்னு நினைச்சோம்னா அவங்களோட சேவை வந்து ரொம்ப ரொம்ப பெரிய விஷயம், ரொம்ப மகத்தான ஒரு சேவை. அவங்களுக்கு ஒரு சின்ன ஒரு நம்ம அவங்களுக்கு நினைப்பச்சதுக்காக தான் இந்த ஒரு மெடலே வந்து பிளான் பண்ணோம். சோ இந்த மெடல் வந்து இட் வில் பி சம்திங் லைக் ஒரு பெரிய ஒரு மதிப்புக்குரிய இதை வாங்குறதுக்காக போட்டியும் வந்து ரொம்ப அதிகமா இருக்கணும். இந்த வருஷம் 4 பேர் அப்ளிகன்ட் தான் வந்தாங்க, பட் 4 பேருமே வெரி ஒர்த்தி அப்ளிகன்ஸ். But I'm sure in future I want more and more people to apply and then to fight for it, because it's a prestige to have something associated with their name. So I'm very, very thankful to each and every one of them. So now I request each and and of course Dr. Srinivasan to say a few words on about this award. A couple of things I just want to say. In the version, I mean for lifelong, till the end of it, this award will be sponsored by the trust, which is charitable trust, which is named by my parents. Cambridge Trust trust. So every year we will sponsor. I mean, this year is only 10,000. I want to make it at least 1 lakh, which probably I'll do very shortly so that at least but even otherwise, just the name itself is sufficient. But I'm just saying it will be done every year, and every year my trust will sponsor the sponsored money. And so I just want each and every one of them to say a few words. Let me start with Mike Angekuttu.
Good morning, everybody. And I feel very happy that we have got a Pondicherry Academy of Pediatrics. Because I am a member of Indian Academy of Pediatrics from 1973 onwards. Probably many of you would not have been born. In 1975 or 76, the Tamil Nadu chapter of Indian Academy of Pediatrics was inaugurated. That time, Balgopal Raju was the president. Organizing secretary was Dr. B.R. Santanakrishnan, all big stars, stalwarts. I used to look at them like that. So I was, that time, I was a chipper. After that, from Pondicherry, there used to be only 2 people who were members of Indian Academy. One was Dr. Puri, the other was me, who used to go up for conferences. And in that executive committee, one of us will be a representative from Pondicherry. That is all we have had representation. I used to feel that when is Pondicherry about such a big institute, we didn't have many medical colleges those days. And most of the people were from Tamil Nadu, either from ICH or from Stanley, few from other places, and one representative from Pondicherry. All the time it used to be like that. So we could never compete for awards, because we had never organized any conferences, nor we used to present papers. I got awards also for the papers and all that. But we could, so whenever we apply for some pediatrician, senior pediatrician award, so we never used to stand a chance. Though ultimately I got, because of my PALS courses and other thing, I got a lot for Central Academy of Pediatrics, Indian Academy of Pediatrics, Central Office. So through that I got FIAP, and after that I got Senior Balgopal Raju Pediatrician Award, then Senior Pediatrician Award also. And then of course, recently I was given, it is all an honor. So now I want Pondicherry branch, which has got 6 medical colleges, should come up, and I feel as happy as I remember 74, 75, Tamil Nadu branch. Like that, Pondicherry branch should come up. And thank you, Tirumurugan, for the instituting this award, though I feel that I should do something for this award. So you must accept something from me, as I may not be able to give you a lot of money because I'm a pensioner, plus I'm supporting another big organization. So I'm already supporting a hemophilia society organization. So but I will make a small contribution which you people must accept as my small contribution towards this award and towards the betterment of Pondicherry Academy of Pediatrics. Thank you very much. And thank all my students whom I might have been very strict. I might have fired them left and right and for not doing other things. But still, I feel proud when I see people. Congratulations to PRC, who is getting an excellence award tomorrow, and to Dr. Ramesh, who have all worked under us. And I have many people who have, Bharat is there, who has worked under me. Chitra is there, who has worked under me in builds. So I have worked in 2 institutions. I have many people who have worked under me, and I feel proud whenever I see them. Chandra Kumar was there. So I feel very proud when I say they are my students, because they are all now stalwarts and they are all at the top of pediatrics. I am, as a teacher, I still feel I'm very happy, but still I am very happy with my children. Now my hemophilia children, whenever I treat them, that's what keeps me young still. I'm 78 years old, but still, I still keep going. And yesterday, 2 days back, I happened to be a little harsh with one of the Zipper students who did not take the clinical history properly and did something. I told her, please don't be a Google pediatrician or a laptop pediatrician. Dr. Srinivasan, still at the age of 77, 78, is trying to teach clinical pediatrics still. And he's one of the top stalwarts in teaching. So please be a clinical pediatrician. Taught to be a clinical person and listen to the patients and not look at the laptop. I'm happy many of you at that level are still striving. I hope the present teachers also will teach the students to do clinical medicine and not laptop medicine. Thank you.
Srinivasan sir, you can just. Sir, Dr. Srinivasan is there in the US. So his sir is just joining us.
Yeah, can I tell? Yeah, can you hear me? You're able to hear me?
Sir is just awake just to meet us.
Thirumaran, can I talk?
The volume marla, sir.
Yeah, my volume is okay.
It's okay, sir.
It's okay?
Yes, sir.
So I thank, of course, all the people who have assembled there, all stalwarts, office bearers of IAP TNSC, as well as the office bearers, present office bearers of Pondicherry IAP. So it's a great occasion, and I have been watching right from the first program today. And of course, it's a wonderful event. And of course, our Suresh Babu has mentioned the importance of organizations like that and how the membership should be improved. Okay, so to make a mark. And of course, we heard Rajendran talking about the importance of such organizations and Sendil blessing us. So I thank all of them. And of course, I must say, Tirumurugan has come with this novel idea and asked our acceptance whether we would agree to this proposal of instituting an oration in honor of the 5 teachers he have mentioned. And of course, it shows his gratitude for whatever we have done, whatever, of course, in our own capacity. And he has mentioned, of course, the greatness of some of the teachers. And of course, Dr. Mahadevan is well known for his involvement in care of children with developmental problems, speech problems, etc. And he has been very excellent in this area. And of course, everybody knows about him for his excellence in emergency medicine, especially with regard to promotion of snake envenomation treatment as well as scorpion envenomation treatment. And Dr. Nalini, she is of course senior to me, and she has been always interested in chronic problems. Not that, of course, she's not interested in acute medicine, but she has taken care of all nephrotic syndrome patients, rheumatoid arthritis, and of course, it needs a lot of care. And now you know that she has been very active in hemophilia and bleeding disorders. So her kindness, of course, Dr. Thirumaran has justifiably mentioned that she is doing such a wonderful work. It's highly appreciated by all of us. And of course, Dr. Vishnu Bhatt has been extremely dedicated to patient care, especially neonatal care. And he is known for his punctuality, that you can say exactly, set your watch, seeing where he is walking. And as Thirumaran mentioned, he comes exactly on time, 8 o'clock. And immediately he starts his ward rounds. And each one of us had our own characteristics. Thirumaran's already mentioned. So I thank him for instituting this medal to be given every year for the best. And I congratulate Dr. Rajendran for being the first person to be chosen for this year overwhelmingly. Of course, as Thirumaran mentioned, more and more participants should compete to choose the best. Thank you, Thirumaran, for your gesture, and I'm very happy that the thing has taken off very well. I congratulate all the office bearers of Pondicherry IAP, as well as our mother IAP TNSC for coming and blessing us and starting this event. Thank you so much.
Thank you, sir. It's great having you here. Mahadevan, sir, say a few words, please.
I do not know what to say. I be humble, grateful for all the kind words which
Thiru, I can't hear him well.
has said.
Thiru, will you ask him to talk in the mic?
I know. குடும்பம் பெருசாகும் போது நிச்சயமா அதுக்கு சில கிளைகளையும் நம்ம பண்ணி கொடுக்க வேண்டியது உங்களோட கடமை. ஒரு இடம், ஒரு பிளாட்ஃபார்ம் கொடுக்க அவசியம் ஏற்பட்டு இல்லை என்றால் நீங்க சொல்ற மாதிரி சவுத்துல இருக்கிறவங்கள நிறைய ஸ்ரீனிவாசன் எல்லாருமே தொடர்ந்து நிற்க குத்து விளக்கு அப்படின்னு சொல்லுவாங்க. அந்த மாதிரி இருந்துட்டு போறாங்க. What is important is life will be that we know that every product comes with an expiry. But what can be left behind are only fond memories. And I think the fond memories of association. The moment you meet somebody, immediately எங்க மடைகிறந்த வெள்ளம் போல நம்ம அந்த சின்ன சின்ன இதெல்லாம் எனக்கு ஞாபகம் இருக்குது. திருக்கோயில் பாஸ்கர் அப்படின்னா எனக்கு நல்லா தெரியும். அவர் the way in which he will refer a patient to the emergency and அதுக்கப்புறம் நான் பாண்டிச்சேரிக்கு வந்துருக்கேன் அந்த பேஷண்ட் எப்படி இருக்கீங்க அப்படின்னு கேட்பாரு. The kind of involvement is what takes us to the patient. We become one with the patient. So அந்த மாதிரி இருக்கிறதுக்கு வந்து அந்த பிளாட்ஃபார்ம் ஜிப்மர் கிடைத்தது. இப்போ ஜிப்மர் நான் சொல்றேன், முதல் நாள் வந்து எப்படி பீடியாட்ரிக்ஸ் ஜாயின் பண்ணிட்டு வந்த உடனே 2 மாசம் நீங்க எல்லாரும் ஜிஹெச்ல போய் ஒர்க் பண்ணுவோம். ஜிஹெச்ல போய் ஒர்க் பண்ண உடனே அப்ப டாக்டர் அகஸ்டின் பால் அவர் தான் வந்து ஹெட் ஆஃப் ஜிஹெச். ஸோ அப்ப ஜிஹெச்க்கு ஒரு டிவிஷன் வந்து பாண்டிச்சேரி பீடியாட்ரிக்ஸ்க்கு ஜிப்மர் பீடியாட்ரிக்ஸ் சத்யகுப்தா டாக்டர் அகஸ்டின் பால் எல்லாம் வந்து அந்த
அப்புறம் 2 மாசம் கழிச்சு நான் ட்ரீட்மெண்ட் தெரியும். ஸோ எனக்கு ஃபர்ஸ்ட் பீடியாட்ரிக்ஸ் டச் வந்ததே. ஸோ இம்பார்ட்டன்ட் திங் இஸ் பேஷன்ஸ் ஆர் அவர் எக்ஸ்பர்ட்ஸ். அந்த ஒரு கான்செப்ட் வந்து எனக்கு அந்த ஒரு இதுல கிடைச்சதுதான். அண்ட் எனக்கு அடுத்த சான்ஸ் டாக்டர் ராமச்சந்திரன் இருக்காரு. ஸோ we got the medical excellence award here. So PRC also knows the importance of working with the people and working in a large number. நம்ம வந்து பார்த்து இதான் டாக்டர் ராமநாதன் டாக்டர் ஈரோட்ல அவர் சொல்லுவாரு, என்னப்பா ஒரு பாட்டு ஒரு படத்துல வந்து எல்கோசின் வச்சுக்கலாம், ஒரு படத்துல பெடர்பின் வச்சுக்கலாம், நம்ம ஓபிடியை சீக்கிரம் முடிக்கலாம். It is that may be one, but what is very important nowadays is we need to explain the patient the disease. We need to explain the patient the prescription, and also we need to tell them for a timely refill of that. The timely refill of the prescription ke நான் நேத்து வரைக்கும் மருந்து இங்க 4 நாளைக்கு நீ மருந்து ஆயிடுச்சுன்னு எனக்கு தெரியாதுங்க, நான் அதனால ஒரு 4 நாளைக்கு விட்டுட்டேன். withdraw pidamar given for one day, next day the patient will come with a break. It will not happen for other drugs, but it can happen for people. So these are the 3 important things which Chipman has taught us. Explain the disease, explain the prescription, and talk about timely refill of the prescription. So the market platform, I think it is solidly, but what I am saying is it is what we are now seeing is the agility of the young and maybe the wisdom of the old, and our wisdom has come through our mistakes. Thank you very much for this opportunity.
It's perfect, and like weight, and the scale sheet. And undergraduates, the way he would put down things critically, review the thing, and write the problem. Right from the beginning, right from first year of MD, he was one of my students. I'm proud to say he and Vishnubat and Meena were one of my students. I would show to the students, I kept it as a record till I was a jibber to show to the students what Mahadevan used to do. So perfect used to be his case sheet and his reasoning. Right from first year of MD, I've always appreciated it. And his method of teaching, simple method of teaching to students. So they would understand, even a commoner would understand the way he would put things. So that empathy is what impressed me to the patients.
Thank you. ஒரே ஒரு இது ஆட்சி யோகம்னு சொல்லுவாங்க. இப்போ சொன்ன மாதிரி முன்னாடி நம்ம ORS சிங்கோட ப்ரொமோஷன், அதுக்கு அடுத்தது வந்து இந்த இதோட இந்த விழா ஆரம்ப விழா, அதுக்கு அடுத்தது வந்து நம்ம நாளையில இருந்து தாய்ப்பால் வாரம், which has become now the world movement. It's just not a movement which was started by the Breastfeeding Promotion Association of India, which Dr. Srinivasan had worked day and night for that. Now எல்லாமே சேர்த்து என்ன இருக்குன்னா சிம்பிள் பெருவெள்ளம்ன்றது இப்ப நம்ம வந்து ஆடி மாசத்துல இன்னும் 18 நாள்ல ஆகஸ்ட்ல ஆடி. சோ அந்த மாதிரி நம்மளோட ஒவ்வொரு எஃபர்ட்டும் has its own let's keep moving, let's keep going. பட் இதுல ஒரே ஒரு ரொம்ப முக்கியமான என்ன சொல்ல விரும்புறேன்னா, இந்த போஸ்ட் கிராஜுவேட் டீச்சிங்கை பொறுத்த வரைக்கும் டாக்டர் ராஜேந்திரனோட இந்த எனக்கு நல்ல ஞாபகம் இருக்கு. இந்த முதல்ல நம்ம கொரோனா ஆரம்பித்த புதுசுல டாக்டர் அருண் கன்சல் டிஜிஐல இவர்கள் வச்சு நம்ம ஆரம்பிச்சிருவோம், பட் let it keep going அப்படின்றது அதுக்கு கொடுத்த மிகுந்த உற்சாகம் இருக்கு. கோயம்புத்தூர்ல 3 கான்ஃபரன்ஸ் கிரிட்டிக்கல் கேர் காங்கிரஸ் அவர் நடத்திருக்காரு. Plus, that would be not, I think I had been one of the co-examination. Remember when we conducted the MD exam online during the thing, and அங்க எவ்வளவு ரொம்ப சிம்பிளா வெளியில தெரியல அவங்க the amount of work which they are putting up at that particular part of the. So I think I am among the stalwarts. This is a memory which will I carry like.
Thank you, sir. Thank you very much. Have Dr. Chidambaram ma'am. So Srivan sir wants to say a few more words.
Yeah, I just forgot to mention important people in my life as teachers. Dr. Purusu Balakrishnan, who diagnosed typhoid pneumonia and published it. And of course, Dr. Indra Narayanan, who has started the neonatology unit. And I, of course, I must thank the GH junior specialists and senior specialists, where I started my senior house agency. And the number of patients are so many. And then, of course, we have been given full freedom to manage these cases. And I have to specifically mention that trio Purushottaman, Dr. Jayaraman, Dr. Augustine Paul, who have been also teaching in the rounds when we are posted mostly in GH during the initial stages of JIPMER, when there was a unit from JIPMER in pediatrics in GH. And I thank all of them. So I have to put it in words as well as in letters, their contribution to my learning also. And of course, it's very important to mention about my teachers.
So we have lost the signal, sir. I'll just get back to you once we are ready, sir.
Thank you so much.
Just 1 second.
So each institute has its own flavor and its own discipline, its own ambience. One institute cannot copy another institute. நம்ம இந்த காப்பி அடிக்க ஆரம்பிக்கும் போது தான் the cut and paste philosophy should go away. We should be our own. We should be our own and try to do our best. Thank you.
Ask them to hold the mic nearby. Yeah, thank you, Chidambaram. Talk in the mic.
I'm extremely honored to be here on the days with so many stalwarts in pediatrics. Sometimes I wonder, what am I doing here among all these stalwarts, advocates, and giants of pediatrics, being a non-medical person? Probably it is just reflected glory, like vicarious responsibility. My association with the other 4 people in the award, I have known them for almost half a century, or some of them even more. Dr. Nalini and Dr. Srinivasan were with me when I did my diploma. Dr. Nalini did her MD and Dr. Srinivasan was my classmate. And Dr. Mahadevan and Dr. Vishnu Bhatt were ardent and earnest young students when I was the physiology teacher. That's how my association goes with them. But this is a story where the state and the center have worked in tandem with each other. And throughout my career as a pediatrician, these people have been very supportive and friendly with me. And many a time I have resorted to their help for even minor problems. In the days before zinc and pre and probiotics, ORS was the mainstay in treatment of diarrhea. And Dr. Nalini time and again used to say, "You are the only pediatrician writing ORS. You have not even gone to the extent of writing antibiotics." Because the main reason was not to feature into areas which is unknown to a non-academician. Most of my time was spent in seeing almost 100 patients per day in state as well as in private practice. And over the years, you learn to pick up some points, some signs, some symptoms, which you use as your own way of diagnosing. And most of the time, I was able to do a good job. That's what I thought. And always these people, Dr. Nalini, Dr. Srinivasan, Dr. Mahadevan, Dr. Bhatt, were at my side and looking over my shoulder and helping me when I was in problem. And in later years, it was Dr. Bani Raman and most of the time Dr. Thirumurugan who were there as a guide to me. It was a case of the student surpassing the teacher. And I'm very grateful to all these stalwarts for being by my side. This Pondicherry Academy of Pediatrics is the brainchild of Dr. Thirumurugan, I think. And according to Arabindo, he has such a good heart that the entire universe can be held in it. And he is just thinking of other people, staying in the background and doing a lot of things to push Pondicherry Academy in front. And I'm very thankful for all that he has done. And floundering in a sea of inadequate knowledge, I'm indebted to the IAP TNSC for helping with their webinars, especially I have been attending conferences for more than 2 decades, and what little I could pick up I used in my practice. And for the past 2 years, under the auspices of Dr. Rajendran, Dr. Ramesh Babu, etc., I had the opportunity to listen to webinars. A point here and a point there has helped me in my practice in dealing with the children. Thank you all very much who have contributed to my growth in pediatrics. Thank you.
Thank you, ma'am. I think by now we know who is the winner for this year's inaugural NSVMC award. We have none other than Dr. Rajendran. Because we are running short of time, I'm not going to talk in detail about what a great achiever he is. But let me just say that it was a unanimous and decision. I mean, even the scoring points, he scored much better than some very capable candidates. And so we are very happy to have sir. Now we request the Dr. Chidambaram, Dr. Mahadevan sir, and Dr. Nalini ma'am to give the award to Dr. Rajendran, and then we can proceed with this oration after the vote of thanks.
I am also there, holding there.
Yes, sir. Sorry, sir.
I am also there to
Yeah, yes, sir. You're here holding it on.
Yeah, it's a
Maybe
pleasure
you can
to
ask sir to hold it on your behalf, sir. Sir, wrong, sir. See, sir. You can represent Sriyan, sir.
Rajendran, I am very much there.
Great honor, sir.
It's now 3 o'clock here AM. I am keeping awake.
Sir, you are more fresh than any one of us here, sir.
Shivaratri for me.
Sir,
கேமரா அந்த பக்கம் காமிக்க சொல்லுப்பா. கொஞ்சம் அந்த பக்கம் திருப்புங்க. Very good. Thank you. கொஞ்சம் காமிங்க அவங்கள, கொஞ்சம் வழிவிட சொல்லுங்க அவங்கள. ஓகே, தேங்க்யூ தேங்க்யூ. Sir, I am also holding it, sir. Rajendran.
Thank you, sir. Thank you, sir.
Okay. Thank you, Tirumurugan.
Thank you, sir.
You can keep it in the original position.
Thanks.
Congratulations, Shanmugam.
Thank you, sir.
Ramachandran,
Yeah.
vanakkam.
Vanakkam, sir.
Congratulations.
Thank you, sir.
Thank you, Chidambaram, for your.
Madam, please. Sorry.
This year, the prize money is 10,000 for the award, and of course, just
Yeah.
and give it.
So I am going to contribute. You have to accept it.
And it's really it's an honor to me, and getting 100,000. I want to donate this money to Hemophilia Society of.
Great gesture.
Persons in Hemophilia Society.
Wonderful gesture. Congratulations.
Great honor. Thank you very much.
Okay.
Yes, sir. Yes.
I now request Raghunath to present the senior pediatrician of Krishnamurti, sir.
Congratulations, Chidambaram. Humility personified.
Good afternoon, everyone. On behalf of Pondicherry Academy of Pediatrics, I thank you all for participation in this program. I thank our teachers for accepting for this award, and I thank IAB President Dr. Ramesh Babu sir and Secretary Rajendran sir for gracing this opportunity. I thank each and everyone for helping to make this program success. I will thank the people behind the scene who have helped us to conduct it successfully. Thank you.
Another one small announcement. I mean, we had the lower competition for the Pudui Pedicon 2020, and we had two people who whose entries were accepted, and then we merged them to create our logo. So one was Dr. Krishnamurti sir. So we thank you very much, sir. The other was Dr. Gayatri G. Nair. Right? She was a postgraduate then at Manakala Vinaya Medical College, and right now she is working as a AP in Lakshminarayan Medical College. So, sir, so we are just this lower competition. We had an award of 6,000 rupees. So it was split between Dr. Krishnamurti and Dr. Gayatri. Oh, she's there. Oh, sorry, she's there actually. Please come, please come. No, Sorry. Sir. Thank you. Now we request we will start the next session shortly within the next couple of minutes.
Pediatric infectious diseases have been reported since before this and were always closely linked to the evolution of medicine. Furthermore, the impact of appearance of new hosts in the pandemic, very low birth weight infants, preterm infants, and the emergence of new viruses have produced a challenge to the pediatric fraternity. I call upon Ramesh sir to speak on how to go about the infections. Sorry, I call upon Ramchandran sir to speak about the lab investigations.
I now invite Dr. Ramesh sir, past president, IIT Bangalore chapter, executive member of the AIDS Center IIT, NNF Tamil Nadu State chapter, BPA coordinator, and past HOD of RMSH, medical superintendent of Ramukta Medical College, and also currently the Tamil Nadu Medical Council awardee for professional excellence in medical field for 2022 to share the session and moderate the session. Dr. Ramesh sir, and introduce the speaker of today's session.
Mic pressing, sir.
At the outset, I must thank profusely Dr. Thirumurugan for bringing this opportunity. And more than that, I must appreciate and congratulate him for initiating and awarding the names of giants of pediatrics in Pondicherry, Dr. Nalini, Dr. Srinivasan, Dr. Bhatt, Dr. Mahadevan, and Dr. Chidambaram. As he was a student of them, but I had an opportunity to work for a short time as a senior resident in 1983, a very short time. Then I went on to Karnataka Medical Service. I always used to wonder because they are mentors also for me that they deserve a B0 award from the whole of India. But this time I am happy that they are in a position to give awards to the best in pediatrics. Thank you. And to the audience, I don't have to introduce Dr. P.R. It is like carrying gold nailing. So what all I can say is he was a past director of the institute and he is a present dean of Ramchandra Medical College. He is also a editor in chief of and he is my good friend for 3 decades. And we have worked as co-examiners, co-chairpersons, co-speakers. On to you, sir. Over to you, sir.
Thank you, Dr. Ramesh. Respected teachers, seniors, senior pediatricians, fellow pediatricians, and postgraduates and dear friends. There are multiple reasons for me to be extremely happy to be here. First, I'm almost the son of the soil. Studied here, spent one of my best 10 years, or probably I'd say probably 11 years of my life. When you are young and you learn and you develop friendship and you really know how life is and your professional life foundation is laid in this place. Second is this is an occasion where all my teachers are being honored and an oration and a medal is installed in their name. Professor Nalini, Professor Srinivasan, Professor Mahadevan, Professor Vishubhat, and Madam Chidambaram, they were all my teachers. Because just like Dr. Mahadevan, I also had to do my stint in GH where Dr. Chidambaram used to take meticulous rounds in the MH, and we were all the beneficiaries. Third is, I have my real pal, Professor Ramesh, because we were doing PALS courses together for so many sessions. So the pal, as you know, the friend, and he's also extremely capable and an experienced teacher, very, very active in the field. So thanks for the opportunity. And I thank the office bearers of Tamil Nadu State Branch and also the Pondicherry chapter and others, the Viluppuram and Kadalur branch office bearers also for this wonderful opportunity. The topic is rational lab investigations in pediatric practice. Today's program is mainly to honor the great pediatricians and seniors. So I will try to make it brief, though the time initially was given 45 minutes. I will try to make it in around 30 minutes. And there may be certain things I may just go through fast. And if there is a time for interaction, we will take it up later. Because this is a topic which general pediatricians, academicians, everybody have some time to think about before they pin some of these investigations. So all of us want to do a good clinical pediatrics. We want to diagnose things mostly by our clinical methods and as much as possible with least expenditure to the patient and least discomfort to the child. We do not want a child to be bled unnecessarily or unnecessarily subject the child to be collected urine or something. But is it possible in this era of litigation and other things? Can we escape from investigations? As a matter of fact, in abroad, other countries, the investigations take a precedence, but still, we as the teachers, as well as the pediatricians, the seniors, and also the learning pediatricians learn that is the clinical pediatrics which has an upper hand. My scope of talk will be some brief outline about the history of laboratory medicine and what are the principles in ordering and interpreting the laboratory investigations in the context of infections, that too short-term infections. I'm not going to touch upon all the long duration infections because the time is not there. And I may not also touch some of the things which are not become very common, like malaria has become almost nil most of the Tamil Nadu. So I may not be touching much on some of those infections. And I will try to take some illustrative cases, show that how we can order, how we can interpret the investigations. Hippocrates, the one in 300 BC, probably advocated the urine examination to diagnose diseases, and some concept about the microscope came later. Leeuwenhoek, his name we have heard many times. He started looking at the bacteria under the microscope. William Osler instituted the Ward laboratory, the side lab, which our Medical Council of India and NMC are talking about, was actually the concept of William Osler. And we cannot forget that giants and the doyens like Leeuwenhoek for the microscope and the description of the bacteria, and Louis Pasteur, actually the father of modern microbiology. So you can probably look at it in various phases. In 18th century, the bedside medicine was the one which has given a lot of importance, like William Osler's. And the late 18th century and 19th century came the hospital medicine again. William Osler started introducing the lab medicine in the wards. And from that time onwards, laboratory medicine has served as one of the fastest growing branches which have helped the clinician. The idea is to help the clinician. But always remember that in the hierarchy of clinical diagnosis, it is the history. Later only come the examination part, and to some extent, the laboratory comes to play. So please remember the advice of the doyens who say that always follow history, then interpretation and investigations and treatment. And don't start empirical treatment, that is mismanagement, then start investigating, then start asking the symptoms and signs. So you should have our hierarchy, good history, almost the diagnosis is made, confirmed by the physical examination, to some extent, the laboratory investigations may corroborate it. In this talk, we'll be looking at some of the type of investigations, when should we order it, and how should we interpret it, and the clinical diagnosis and the treatment will not be covered. The scope of lab diagnosis is quite enormous. You can start with a simple microscopy to identify the organism, which is almost the lab bedside, the ward lab has almost disappeared in most of the medical colleges. Though the NMC is saying sometime during inspection they are opened up. There is hardly, I will say, anybody looking at under the microscope how the organisms look like. Still, we have pediatricians, practicing pediatricians like Dr. Palaniraman and my own senior, Dr. Madhavan in Chennai. They still look at things at the microscope in spite of their busy practice. They look at a urine, or some technician might have prepared the slide, but they still look at it. So we should get into the habit of doing this, or at least when the lab has made something, we should go and verify, go and check it. The culture, the conventional blood cultures, now the advancement have been made where you can get it at much more faster rate like BACTEC, and microbial antigen identification, faster identification methods are there. Molecular diagnosis has come up in a big way, and still there are some infections where you have to depend on the antigen identification or the serology, because the other things are not either viable or not available. Please remember, identification, the causative organism is the gold standard, is a definite proof. That's why microscopy, fast lab tests like BACTEC and other things, and molecular diagnostics and culture are still the best way you can confirm an organism. Try to identify the proper specimen for the culture and sensitivity before the antibiotics are started. So this is time and again emphasized. Very, very rarely that you are pressurized to start an antibiotic before doing the cultures. Maybe something like a child who comes in a septic shock or a meningitis. So these are all very, very rare situations. Most of the times you will have time to send the lab investigations. The culture positivity comes down, but still you may get a recovery of an organism even up to 48 hours. So please persist with that. Wherever available, make use of the nucleic acid identification. You may not get the antibiotic sensitivity, but at least you will know the organism. And wherever not possible, indirect methods you may have to depend on. In spite of all the lab advancements, it is the clinician who decides how to send the specimen, and you have to train your juniors, the other people, including the parents, the mothers, how to collect a proper specimen and send it. The success of if at all you are going to order in lab investigation, the majority of the success, especially in microbiologic diagnosis, depend on how it is collected. Appropriate specimen is very important, and adequate volume is important, especially in blood culture. The broth and how much blood is taken, the ratio is very important. Aseptic precautions, especially in a normally contaminated area like urine culture, how you prepare before taking the culture, and the skin aseptic precautions before you take the blood culture. And remember that whenever you are taking some pus or some secretion, always try to get it as a secretion rather than taking a swab. That is very important, because the recovery is much better when you take that fluid and collect it in a sterile tube and send, rather than take it in a swab. And prompt transport is very important. If at all you cannot transport, you must know which type of the specimen, how it can be stored. For example, you have to refrigerate the urine because you don't want other contaminations to grow. But you cannot refrigerate blood or CSF because the temperature may inhibit the organism, may kill the organism. That has to be in the normal room temperature, because there will not be any growth or any such thing which will be taking place in the blood or the normally sterile fluids. In OP practice, do we order the lab investigations? Hardly ever. If you are a busy practitioner, you may see 50 cases or 60 cases. Probably 3 or 4 or 5 maximum you may order, depending on the season. Sometimes in dengue season, you may order slightly more number of tests. Otherwise, by and large, most of the practitioners will remain around 5% or less for sending the laboratories. Usually, this is what I generally follow. So that's what I put it. The first 2 to 3 days of fever, generally, no investigation is ordered. Of course, there are exceptions. Generally, tests are ordered after 4 or 5 days of fever. And seasons like dengue, for having a baseline, sometimes you may order the test in the first 2 or 3 days. Which are the situations you have a low threshold for doing the laboratory test? Newborns and children who are young, and due to some other reasons like immunocompromise or some other underlying problem, or the child looks ill. So this is your clinical decision which will make you do a lab investigations other than these rules. But you should know what lab test you must send. Should it be culture or should it be serology? Should I just send blood culture or should I send vital? When to send? Is it the right time? On the 5th day of fever, should I send NS1 or should I send the antibodies? 3rd day of fever, can I do a IgM ELISA for strep typhus? So that kind of thing we should go in your mind. And probably this should come first. Should I send at all? I can have a fairly good diagnosis, make a clinical diagnosis, probably it is viral only. I may not even need to send an investigation. And know your lab. Just like know your neighbor and know your the prospective bride and other things. You have to do some search for your lab. You have to really know whether that lab is good. Sometimes, if you don't have good lab, better not to send the test rather than getting into all the wrong problems. Better to remain a bachelor sometimes. Can my patient afford it? Also, you have to keep in mind. Okay, so that is also very, very important. You have to know your customer, whether you can order that test, whether they will really do it. That also you have to keep in mind. Coming to the case scenarios, 2-month-old child with fever for 2 days, poor feeding and reduced activity 1 day, sick looking, febrile child, anterior fontanellase level, systems are normal, total count is 8,900, polymorphs 56, lymphocytes 42, eosinophil 2, CRP negative. So I'm just trying to put these case scenarios only for reiterating some of the laboratory investigations. What is the relevance of these laboratory investigations? I am trying to give a background these case scenarios. Another case, 5-year-old, high-grade fever, 5 days, systemic examination is normal, laboratories, you have done a hemoglobin 10, total count is 24,000, polymorphs 80, CRP is 22. The first case, the second case. Now, what are the issues in sending all this blood counts and CRP? In a symptomatic child, if the counts are normal and the CRP is normal, what do? Do the counts and CRP differentiate between viral and bacterial infection? When will CRP increase and fall? And alteration of CRP values following antibiotic administration. The total count, generally we go by 4,000 to 11,000 as normal, and more than 11,000, it may indicate a bacterial infection. It doesn't mean that it is indicative of bacterial infection. Non-infective conditions, stress also it can increase. Leukopenia is seen other than viral infections, typhoid and malaria and strep typhus also. Stressors can cause an acute leukocytosis. By itself, it's a poor predictor of bacterial infection. But along with many other things you can think of. Okay, so you have 3 or 4 things: constellation, then total leukocyte count as a bearing. Differential count, again, just like total leukocyte count, neutrophilia is seen more commonly in bacterial infections. But in children, you should know what is the normal neutrophil count. As a pediatrician, we know that. Okay, generally, whenever we see in children a neutrophils increase at least up to 5 years, we always think that along with the total increased total count, whether it is suggestive of some bacterial infection. What is the commonest we are going to get at in our practice? Mostly urinary tract infection, rarely some respiratory infection. Okay, eosinopenia, if you see less than 1% of eosinophils from the total count, think of typhoid. This is only a guideline. This is not again not an axiom. Lymphocytosis, you can get in childhood viral illnesses, marked increase in lymphocytosis, think of pertussis. If it persists, probably it may indicate something like a hematological problems, malignancies. Peripheral smear, in identifying the bacterial infection, we used to talk about this toxic granules, band neutrophil ratio and other things. Frankly speaking, not being done much, except the lab person, if he tells you, then these are all useful. At least for post-graduation, other things you must know that normally there are some granules. When the number increases to too much, you call it toxic granules. Normally, you do not get vacuoles in the neutrophils. When they are present, more immature neutrophils are coming out, probably due to the stress of bacterial infection. Coming to the acute phase reactants like CRP, ESR, they can rise in not only in acute, though they are called acute phase reactants, they can rise in chronic inflammations also. Please remember that other than infection, you can get an inflammatory arthritis. In COVID times, you would have seen in MESI cases and others also, they are markedly rising. Kawasaki, they can rise. So many other conditions also they can rise. They are actually produced due to the stimulus by various cytokines. Most of them are produced by the liver. These are all the various types of proteins. From the liver, they are poured out due to the cytokine stimulation. These are all called positive acute neutrophil, acute phase reactants. The negative acute phase reactant, most important thing is albumin. The cytokines suppress the albumin production, increase the production of CRP and other proteins like fibrinogen, ferritin, other things. That's why you get a positive result. ESR actually measures the fibrinogen and it may be affected by RBCs, the number of RBCs, size, shape also. So these are all the caveats, sometimes we must remember. They can be elevated in renal diseases. That also we have to remember. It doesn't have a very great discriminating power. Even a very high CRP, you can get in infective endocarditis, you can get in Kawasaki, you can get in malignancy, collagen vascular diseases, even more than 100. CRP, please remember, interpret your lab value. That can be given in a deciliter, that is 100 ml, or it can be given in liter. So if more than 10 milligram per liter is considered suggestive of inflammation. Anything less than that is not very useful. And again, in multiple conditions, it can be raised. More of a positive CRP because of its many other conditions positive. A negative CRP rules out probably an infection. CRP estimation, the CSF, is not of any use in bacterial meningitis. But the CRP is very high, generally in a context of a fever, in an acute illness, probably one can think of a possible bacterial infection. For example, it has been shown that when it's more than 50 milligram per deciliter, okay, so we said that, 50 milligram per liter, 50 milligram per deciliter or 500 milligram per liter, one should, there is a possibility of bacterial infection is very high. 500 milligram per liter, okay. CRP is generally, there is one thing newly which has come, high sensitive CRP. Routinely, it is not recommended in children. It is recommended for some other condition like various atherosclerosis and other things, which are all the stress-related problems in adults. We generally don't do it in pediatric practice. Procalcitonin is a new kid in the block. It has been found to rise slightly earlier, but whether it has got a very great advantage over CRP is still a big question. Please remember that blood counts to be interpreted with a clinical picture. Leukocytosis may be non-specific. CRP only indicates inflammation and does not differentiate between bacterial and viral infections. The third case, the child is again short duration illness, vomiting off and on, and the child has got normal AF, temperature is 100.6, hydration normal. What test should order? So generally you are going to suspect the first 2 days viral fever, dengue and other things. You can do in a baseline in a dengue season, probably just to keep the patient's mind at rest. An NS1 antigen can be done and the baseline counts can be done and a baseline hematocrit can be done just for follow-up purpose. But one has to tell the parents very clearly for what purpose you are doing this investigation. You are not going to treat the child any differently by getting this investigation results the first 2 to 3 days when you do not suspect that it will be any serious bacterial infection. You can tell them that this is only for the baseline purpose. And if at all, in a young child less than 2 years, short duration illness, one investigation which may be very important is if the child is looking a bit ill or something, you will have to do a urine culture. So that is one thing you should remember. And empirically, don't start antibiotic if at all it's possible. Send the urine culture, because that is probably the very most difficult thing to do in a child which is very, very young. This child CBC is normal. Urine showed 6 to 8 per cells. More than 5 per high power field is suggestive. 48 hours, you got the urine culture, which came as E. coli 10,000 colonies per ml. So issues in this thing, how do you interpret this report? The type of urine collection depends interpretation. If you do a catheter sample, this is important. If you do a midstream sample, this may not be important. A catheter sample, 10 to the power 4 or more, in the context of bacteria, the pyuria, you can probably think of most probably a urinary tract infection. Other things like leukocyte esterase and nitrite in urine can be done along with the bacteriuria, along with the pyuria. These things have a higher predictive value. Suprapubic puncture indicated in children, mostly not done routinely. Some institutions may be doing. In children who are not toilet trained, probably the best way to do is a clean catch, putting a catheter. Relevance of colony count and how do you interpret, I just mentioned. What lab tests are useful in the diagnosis of UTA before the culture reports, especially in less than 2 years, I mentioned leukocyte esterase and nitrite as in combination, and lot of importance given this WBCs as an enhanced urine analysis, put in a newborn chamber, uncentrifuge this thing, and also do a gram stain. Again, in clinical practice, I am not seeing it being done anywhere. Okay, mostly people depend on clinical picture, whether the muscles are there in high number, the child is sick, they collect the urine, start the treatment, and then go with the clinical progress of the child. And by the time 48 hours, they will be getting the culture report. The manner in which urine culture is collected report. 80 to 90% of the urinary tract infection management is collecting the report. Proper collection of the specimen. If you are able to collect properly, transported it, the job is very, very easy. Okay, because you don't want to get some contaminant. This also adds to the burden of the patient's pocket. Okay. Clean catch only if there is no other option, and also the child is toilet trained. Cleaning the genitalia with just as clean water or some mild antiseptic may be sufficient. Suprapubic aspiration, the false positive is less. Catheterization is also only around 6 to 10%. Clean catch is also probably around 10 to 20%. Back specimen is probably to be only never to be encouraged. So in a catheter specimen, I already mentioned. So transporting the urine, also I mentioned 1 hour. Otherwise, you have to refrigerate and send it. Culture, probably plating should be done, the lab within 4 hours. So urine to be collected before starting antibiotics, not toilet trained, but to do catheterization, prompt transport, suprapubic only in some doubtful cases, and when the clinical condition is extremely warranted, child is very sick, you have to start, there is no other way you can collect it. Correlate the culture reports clinically before initiating the antibiotics. Case 4, fever, sore throat. This is a case I can just straight away tell you that tonsillitis. Okay, the issues in tonsillitis is, should you send a throat swab for all cases of tonsillitis? How to interpret a throat swab culture? And rapid screening tests like rapid streptococcal antigen vis-a-vis the throat swab culture. If you use a clinical criteria like a Centaur criteria, there are 5 things which are given, like a typical age and the high-grade fever, tonsillar exudate, that is the first points, anterior cervical adenopathy and adenitis, not adenopathy, adenitis, and absence of cough. Each one of them has got a 1 point. If there is 4 or more than 4, probably you can empirically start antibiotic if you don't have the culture facility. Only thing you have to remember is you have to give the antibiotic for total 10 days. Those which 2 or 3, you are doubtful, you can either wait or send the throat swab for culture. That is the group where you require to probably to send the culture. If you want to wait and you want to do the culture later also, up to 8 or 9 days in acute streptococcal pharyngitis, you can send the cultures. Clinically differentiate, try to differentiate by using the center criteria. Do not rely on ASO for acute tonsillitis. That is only for rheumatic fever, not for diagnosing and treating acute tonsillitis. Throat swab cultures, if at all possible, do it. Otherwise, the parents will never believe to take the 10 days treatment. Okay, you also won't believe to take the 10 days treatment. The 10 days treatment is more important for eradicating and preventing rheumatic fever, not for treating just the streptococcal infection. Please remember that. Probably I will stop with this. Just have a few this thing about when do you order these various tests, at which point of time. So just regarding the serology, in dengue, mostly you are going to depend on the counts, the hematocrit. That's how you are going to follow. The first 4 days, probably NS1 is best. 5 to 7 days, probably both are ideal, both NS1 as well as IgM ELISA. And the later, probably you have to depend on mostly IgM ELISA. More than 40% hematocrit suggestive doesn't confirm. Some of the well-to-do children, they have a hemoglobin of more than 14 also. So you have to know whether it can be applied, this rule can be applied for all the type of children. So I will skip all this. So a combination of the investigation many a time will give you an idea. When you have a child with a low platelets, if the child's CRP is high, probably you will think of the first group, that is enteric fever. When the child's hematocrit is normal, platelets are normal, and the CRP is high, you'll probably think of UTI. When the child's hematocrit is high, platelets are low, CRP is normal, probably you will think of dengue, unless there is a complication which is developing. Usually dengue CRP doesn't rise much. When everything is normal almost, and the CRP alone is high, probably you will think of a scrub typhus. Okay. So please remember that to send cultures, the first 4 to 5 days, within 4 days, you are likely to get the maximum organism recovery. And 80 to 90%, the culture is sent within 5 days before starting antibiotic. If it is really a case of typhoid, your lab will definitely report Salmonella typhi. Salmonella typhi and Staphylococcus aureus are two of the easiest organisms to be grown. And when they are grown, they are always pathogenic. There is nothing like a contaminant and other things. These do not arise. Okay. Something about blood culture. So please remember that just like urine, blood culture, proper cleaning and other things are very important. Adequate volume, 1:5 to 1:10 blood broth volume is very important. So I will skip all this. Some books always mention a set of blood culture. That means they want each child from 2 sites blood to be taken. In practice, you can think of how difficult it is. Even to do 1 blood culture, it is going to be very costly. Who is going to pay for that? Even in hospitals, they will think a lot of times to set up blood cultures. So probably other than conditions like infective endocarditis, we may not be doing this, or a child who is a catheter-related infection, you may take from the catheter, the peripheral vein, as well as another distant site. Otherwise, don't do it routinely. At least do it properly, 1 culture. In children, you don't have to do any anaerobic culture routinely. Aerobic culture is quite sufficient. I think I'll stop here because of the want of time. Just go to the last slide. So total count, differential count, acute phase reactants suggest bacterial infection if they are raised. They are not confirmatory. Urine and blood culture, gold standard for UTI and enteric fever routine, respectively. Serology after 5 to 7 days for dengue, scrub typhus, leptospirosis, you are going to depend. Generally, Vidal is discouraged in most of the places. Do not depend on the Vidal because of so many false positive and false negative. If at all you are doing, interpret it along with the clinical this thing. If you get a chance, do a second Vidal after 1 week, but most of the time it is not practical. Antigen identification, especially in dengue in the first 1 week. PCR has now come in a big way. We have been doing in now COVID extremely popular. Everywhere almost has become common. Same way in influenza, we have been doing this PCR test. And tuberculosis, of course. Smear study for malaria, but malaria I have not touched much. Thank you for your patient listening. I'm sorry I've rushed through some of them. Once again, my respects and pranams to all the teachers and thought of the Pondicherry branch to have thought of such a novel initiative. All the people, including my dear friend Dr. Tirumurugan, for this wonderful initiative. Thank you so much for the opportunity. Handmade sir. அது ஒன்றும் பண்ணலையா சார்? இங்க வந்துடுறீங்களா? எதுவும் பண்ணல, எல்லாமே போயிடுச்சு.
Thank you very much, sir, for this wonderful right topic, the right time, by the right person. Only a great first academician, astute clinician, the epitome of pediatrics can do this justice to this topic in 30 minutes. You can talk it for the whole day about it. I know that because I see the beginnings. And you rightly said about emphasis about the history investigation that this is a day when people start taking after taking the complaint, they fill up the investigation form. Now it is available in just one form, just to have to pick it. At least in those days we have to write each form. So we used to skip some investigation. And yeah, that's a period on.
I think it's working.
Clinical practice, that is, you have to make, I also insist on, you make a clinical diagnosis, professional diagnosis, based on that, either to exclude or to confirm the diagnosis, you have to order for the investigation. And I always tell my PGs that a laboratory can only be your servant, cannot be your master. And when the results come, please correlate with the clinical picture, then only you can write the right picture. Don't treat the laboratory, treat the patient. These are all my famous punch words, even my PGs recollect even now. And now the open for the floor for the discussion.
Once I see a consular patch suspected to be with the any bedside investigation, or can I get a clue from the can I get a clue?
Yeah. So the index of suspicion goes up if the immunization is incomplete. And if you see a patch, it can be a membranous streptococcal tonsillitis also. It can be diphtheria also. Being a condition which has got a much more serious prognosis or worse prognosis, you have to, best thing is to refer to your nearest government medical college or somewhere, where they may take a swab. If the child's condition, depending on the condition, they may even start an antidiphtheritic serum and then reassess the child. And probably they may start as antibiotic. The culture may come later as streptococcal group A beta hemolytic streptococcus, but nothing is lost. But you may lose the patient if you don't start the adequate treatment at appropriate time. Nothing. None of them is going to give you a definite clue. Once you see a membrane, I think the best way is, especially in a child, you are thinking that the immunization status is dicey, and the child is also in the age group of more than 5 years or something. So best thing is to send to the nearest medical college. Yes, sir.
This time we had recently a case of diphtheria in Chidambaram. We couldn't get an antidiphtheritic serum there, so we referred to Jigman. And Saira Bond and WHO surveillance medical officer made it possible to get the serum and save the child.
Yes.
That's at this point I emphasize for telling my patients to get vaccination. Those days there was disease, there was treatment, there was also vaccine. Now there is no disease, no drugs are available for treatment, so better vaccine.
Thank you for that. Last month, the Medical College Hospital, we received 3 children with throat patches. And one turned out to be positive for diphtheria. Initially, the child presented with respiratory distress. Sir pointed out we had difficulty in getting antidiphtheritic serum and also for benzoyl penicillin for the same thing. We contacted Director of Public Health and he was able to arrange it in a matter of 6 hours. He we sent a special messenger from Chennai to our institution. Unfortunately, we could not save that child. 2 more children presented with the same complaints. So what we can do is, we clear to starting antibiotics. You just take a throat swab, 2 or 3 swabs, ask them to do it gram strain. Gram positive, basically, you think of a very suspicion, but after taking a swab, you can start them on antibiotics. At the same time, they are also using the swab for culture in special media, some potassium tellurate agar, I think, for the culture, and for the first aid, it came as positive for bacteria. You have to notify it, and you have to start an antibiotic serum. You need not take, but immediately after taking this swab, you got a clinical suspicion of bacteria, got a things like laryngitis and all. You won't be able to do a scopy. You not do laryngoscope also in such difficult situations where you may end up with a tracheostomy also. So you can, let's say you can, what we can maximum we can do is we can look for a gram strain or the throat swab. And taking that swab, we can go for antibiotics and the treatment. And the children were immunized. Actually, it came and they had even that mop of vaccination in those areas. But all those children who come to neighboring district, one from Tirupati district, one from Krishnagiri, and one from Brahmagiri district. Yes, but the child, different age groups. From one child from 5 years old, another child at 8 years old of age, and another child was around 2 years old of age. We lost the child who was 5 years old of age. So we are seeing now re-emerging infections like diphtheria and all.
We used to see in ICH. Sir, the government now the present this thing is DPT only, 5 years. Previously they were using DT. Now it's constant, everywhere it's DPT only. So the only thing is the 10-year the government is not giving now only T. There also now they have started giving the included that decrease diphtheria. So TD has been introduced. So there is no TD. The government program T, small d is there. So the government has made it available. The problem is most of the patients after the first 1.5 years, 2 years, they get out of this immunization network. So they escape from this immunization net. So many times this 5-year and 10-year boosters are missed. And most of the time diphtheria we see, especially in borderline areas, we get in this age group of 5 years, 8 years, 10 years like this. Many times it's missed. Yeah. Absolutely.
So in government institutions, 5 years we will leave it, sir. But for routine TT, tetanus toxoid is not available in government institutions. They usually use TT only. Even though if someone, an adult comes with an injury, instead of TT, they giving only TT. And also for all children or anything from anything, practically TT is not available in government institutions. I think even for antenatal mothers, TD is being given instead of TT. No.
If there are no more questions, sir.
What if DPT is not available? You mean private or government? Private. Yeah, private DPT is a problem. So private, you are probably forced to go for a combination only. There is no other go. With the IPV combination also. Or if you think that they will go, they send it to the government. That's all.
So there are no more questions. I have only a simple question to ask. What about next generation genomic sequence? Will it be useful for investigation of the future to identify newer microbes changing?
The sequencing other things may be more useful for the proneness of some individuals to get the infection. As somebody was mentioning yesterday, Satish Kumar was mentioning. So why a child with a COVID, one child particularly developed more severe problems. So to know the genetic background of the host, it may be more useful. As far as the microbial identification, the currently available methods are extremely popular. Now we have got now the package also, respiratory package and this thing, all this fever package, tropical medicine package, CNS package. So you can do the multiplex antigens at the same time. So that is also now come up. So it is available.
Thank you, sir. Thank you for the
Thank you.
session. I hand over back to the organizers.
Thank you.
Thank you, sir. May I now request Dr. Amit sir to felicitate our speaker, Dr. Amit. I now request Dr. Adam Spencer, the past president of IIT to honor our chairperson, Dr. Ramesh sir.
We'll be together.
Yes, sir. Yes, sir.
We now request Dr. K. Ranitharan, the recipient of NSPMC Medal 2022, to deliver his oration. PMC credit points are there for the CME. Delegates who are interested can register outside the hall by paying a fee of ₹200.
Respected elders and friends, at the outset, I thank IAP Pondicherry and all legends who have supported me as this year NSVMC award. And I really thankful to you. Since they asked to give the oration 45 minutes, I tried to finish within 20 minutes, and because already in 1:45 now. And hereafter we are having another 1 more talk. Yeah. So, next 20 minutes, I'm going to talk about evolution of pediatric emergency management over the past 20 years, but my clinical experience as well as my institution per se. So when I joined Powai Medical Center and Hospital almost 2 decades ago, and Dr. Aswath Mas, my colleague, and he was already there 2 years ahead. And so we had only OPD and a 5-bedded ward. And there was no separate pediatric emergency department as well as PICU. So we have to admit the child in general ICU, and usually the residents as well as staff, they will saw the child like guinea pig like that, because they won't touch the child because they come and see and go. And per se, we are having NICU of a smaller 5-bedded NICU. That's all. The working hours were tedious with no scope for leave or leisure. The OPD always flooded with patients, especially in the night hours. With back-to-back night duties and busy morning hours, we gained immense knowledge, clinical skills, but of course, we excessive emotional and physical stress we had. The OP cases and IP admission were mostly of respiratory pathologies and requiring immediate attention management. You have to come many days and night, and we have to sleep there itself. This made me acquire keen interest in the management of respiratory emergencies in pediatrics. I am proud to say that over past 20 years, I was instrumental in setting up of a separate 10-bedded pediatric emergency department, 15-bedded well-equipped pediatric ICU, 67-bedded neonatal ICU, and as well as general ward and special wards at our center. At present, we have 30 consultants in various specialties. and in our department, and 25 postgraduates DNB, and every year we are having 12 DNBs. And DNB postgraduate was started in 2006, and duties and work pressure substantially reduced after the commencement of postgraduate DNB course. And for the last two decades, various national and as well as state level pediatric conferences and workshops CME were conducted in our hospital. And it's a benefit of consultant as well as postgraduates and the pediatric community. And these conferences are graced by several legends in the field of pediatrics and neonatology intensive care. You can see Dr. Tangivel sir as well as Dr. PRC sir. And so we had a regular pediatric NRP, advanced NRP as well as BALS also. So with the availability of consultants and postgraduates around the clock, it has become possible to give service to 24 quality service out of patient, and as well as intensive care and emergency department. And we that professors constantly update ourselves about the recent advances and management of various conditions both for patients and as well as DNB postgraduate. It's a happy movement in a department party. And staff nurses play an integral part in the management of and outcome of pediatric emergencies. For the past 20 years, that importance and contributions of staff nurse has improved due to regular teaching programs and modules conducted for staff nurse in order to improve the quality of child care. Radiological investigations and interventions has advanced drastically, especially in treating pediatric emergencies. And the past 20 years, our center has witnessed several advances in the field of interventional radiology, which is a life-saving message in a case of intracranial bleed and AVM also, as well as abdominal bleed and liver bleed also. And we are doing a lot of coiling as well as interventional radiology. We are arresting the bleed. And bedside ultrasound has become an integral part of clinical examination in our emergency department. Start with NICU, with HMD, and as well as pneumonia, as well as going for the assessment of dengue, that IVC, look for IVC fluid correction also. And it's important to develop pediatric subspecialties like pediatric cardiology, neurology, as well as nephrology, and pediatric hematology to effectively treat pediatric emergency cases. And the contribution of paraclinical departments like microbiology is very, very important for the success of infection control point of view and as well as antibiotic stewardship. And protocols for hospital infection control as well as antibiotic usage are devised jointly by our expert and as well as microbiologist. Newer diagnostic investigation point of care tests as well as rapid diagnostic kits have helped in the early accurate diagnosis and the initiation of appropriate management. And policies are formulated to avoid unnecessary investigations and antibiotic and emergency setup. And last 20 years, there are significant changes occurred in our ICU, the PICU as well as NICU. Right from centralized pressure control oxygen to extracorporeal membrane oxygen, various advances have been made in the field of intensive care for respiratory pathologies. And with regard to infection control and prevention of emergence of superbugs and as well as antibiotic resistance, and strict hand washing technique with the proper technique is practiced before entering our ICU. And PICU and NICU are completely under the surveillance of CCTV cameras in order to explain the attendants about their child medical condition, as well as special counseling rooms are set up. These rooms are fitted with audio as well as video recording for facilities for medical legal purpose as well as safety of doctors. During our past 30 years, start with my postgraduate period. Initially, the mode of oxygen delivery was face mask and followed by nasal cannula and as well as oxygen boot. And very few only had opportunity to work with the ventilators at the time. Intubation and invasive mode of ventilation was the only available portion of option for the child. And then came other modes of oxygen delivery like NRM and Jackson release circuit, which is provided some benefit to the patients. After that, the CPAP and HFNC and then NIV mode of ventilation had started to revolutionate the management of children with respiratory emergencies. So these newer non-invasive modes of oxygen delivery have substantially reduced the need for invasive ventilation both in neonatal as well as pediatric etc. And over the past 10 years, the advent of CPAP, the use of non-invasive ventilation in our neonatal units has almost come down to zero, except for certain exceptional conditions. So that regarding invasive ventilations, the several advances have come up, both the mode of ventilation as well as the type of ventilators. We are using microwave as well as acute. So in our intensive care unit, we are frequently using the high frequency oscillator ventilation for better lung recruitment as well as minimal lung injury. And inhaled nitric oxide is used often in a setting of neonatal as well as pediatric pulmonary hypertension. And over the past 5 years in our center, we are increasingly use ECMO with a good outcome also. So I found that majority of pediatric emergency cases could be easily prevented at home if parents had prior knowledge about them. So lack of public awareness about common pediatric emergencies and their management prompted me to write articles regarding the same in this Tamil dailies as well as monthly magazines. And the only people who know about these problems, they can pick up the danger signs early and seek medical care. This will improve the treatment outcome. So these all together, I thought to write a book in child health as well as maternal child nutrition in Tamil language, almost 400 pages each, and so that adequate awareness is created and instead of this emergency reduced. So the place other than home where the children spend are school. So many pediatric emergencies occur in the school premises, and most of the time the children are treated by teachers, but they don't know the adequate knowledge and also the clueless. So I realized that it is equally important to educate the school teachers about these emergencies and make them to recognize and handle these situations with adequate knowledge. So I had organized several emergency preparedness programs with the help of the district chief education officer for school teachers in Coimbatore and surrounding Western Tamil Nadu over the last 10 years. So definitely it was improved and they refer the child as well as parents also. The entire approach to pediatric emergency has seen a paradigm shift in the last 10-20 years. So initially each children had their each clinician had their own way of management of particular case based on their experience. Now, various national as well as international pediatric society have come out with clear-cut algorithm and protocols for management of each and every pediatric emergencies. So this algorithm as well as protocol play a major changes because it reduces the error of judgment as well as conducted a lot of trials based upon a lot of trials as well as meta-analysis as well as systematic reviews. They used to formulate a good algorithm as well as protocols. Definitely will help us to narrow down our error also. So coming to that, two important things is in the pediatric emergency past 10 or 15 years. One is a pediatric assessment triangle, one thing, and another one is a pediatric assessment pentagon. These are the two important things you can use even clinical level also, and for an emergency staff nurse also, they can record and handle the child, and he can refer and he can admit the child anything altered. So we won't really miss that any dangerous things. These are two important things we are adopting. And so coming to respiratory emergencies, so important thing is how to approach a child with a respiratory distress. You have to always check respiratory rate over 60 seconds and look for signs of increased workup breathing. That's the important thing. If respiratory rate and workup breathing is okay, you can think of normal. Whereas increased respiratory rate but normal workup breathing, you can think of effortless tachypnea. and which is usually in a non-respiratory conditions you can get in GBS and as well as nephrotic syndrome and some cardiac conditions also. If abnormal one is either respiratory decrease and a decreased work of breathing, you can think of respiratory failure, but need urgent admission, you can need immediate take care of it, PAC, you have to shift it and you have to manage it. Whereas increased respiratory rate, increased work of breathing, usually it's due to respiratory cause, it produces respiratory distress. Coming to respiratory distress, we can anatomical ways we can separate categories like upper airway obstructions and lower airway obstructions like asthma, bronchiolitis. Whereas upper airway obstructions like throat, epiglottitis, foreign body as well as tracheitis. Coming to lung pathology, parenchymal causes like pneumonia as well as ARDS. Whereas pleural causes like pleural effusion, pneumothorax and empyema. And cardiac conditions like cardiac failure due to pulmonary edema. And disordered control of breathing is again central as well as peripheral causes may produce respiratory distress. And so important one is in upper airway obstruction and anatomical side based on clinical signs. You can, sir. So upper airway obstructions that inspiratory stridor is a very important finding, whereas lower airway obstruction and expiratory is a predominant finding. And coming to lung parenchyma, pleural cavity as well as cardiac involvement, the grunting is an important finding, you can get it. And other disordered control of breathing is child may go for normal and as well as bradycardia will be there, bradypnea will be there. So coming to the case scenario one is if a child is having wholly different state, it's a case of ALTP. If supraglottic involvement, you can think of drooling of saliva is important finding. Whereas infraglottic, you can think of not drooling of saliva, but presence of barking cough. So coming to the stridor, you can differentiate febrile and afebrile. Febrile is low-grade fever with croup and diphtheria. Whereas high-grade fever, you can think of epiglottitis as well as bacterial tracheitis and or retrobronchial abscess. And afebrile conditions like a foreign body as well as angioedema also you have to consider. Coming to the group management wise, important thing is if the mild cases, we can do dexamethasone 0.6 mg per kg, you can give it oral. If you are not able to give it orally, you can go for betamethasone nebulization 2 mg. And maximum dose, you can go up to 16 mg. Whereas coming to that severe cases, you can go for along with dexamethasone, you can do adrenal nebulization, you can do 0.5 ml per kg. Maximum, you can go up to 5 ml. And if everything okay, you can discharge, otherwise you can admit at PICU. So next case scenario is case of acute epiglottitis, and so it's important thing is management wise, you have to think of corticosteroids not recommended, and adrenal is a benefit of administration to reduce edema is not established. So prompt effective airway management is a key intervention, and antibiotic you can give according to that protocol. And so all the family members of household contact and as well as close contact group, you can start giving hemoprophylaxis. Coming to the case scenario 3 is a case of retrobronchial abscess. If abscess is severe airway obstruction, you have to go for immediate INT. And if more than 2.5 centimeter after evaluating the CT, you can go for surgical intervention and drainage. If less than 2.5 centimeter means you can go for giving antibiotic, wait for another 24 to 48 hours. You can again repeat CT after 48 hours. If again 2.5 centimeter or worsening, you can go for INT. Otherwise, you can manage with oral antibiotic or IV antibiotic. So next case scenario is child with anaphylaxis. It's coming to here that so management wise, if any anaphylaxis fit into the criteria, and you can, so rule of 3 is a very important thing. One is after taking care of ABC, so you have to do 3 doses of adrenaline, and it's 5 minutes 0 and 5 and 10 minutes. You can do 3 doses. If not improvement, you can do point or you can give 0.1 milligram per kg per dose. You can give it. And the second important thing is you have to look for respiratory distress. So you have to look for the respiratory distress. As a child is having stridor, you can go for nebulized epinephrine, 3 doses you can give it. It's a 5 minutes interval you can give it, like you got be treated with ALTP. And if child is having BC, you can go for 3 doses of nebulized salbutamol. Again, it's a 5 minutes interval you can give it. So coming to the hypotension, poor perfusion, we can do 2 doses of bolus of NS 20 ml per kg over a 10 to 15 minutes interval. If not improving, you need not go for third dose. We have to start with IV epinephrine infusion. So never go IV the epinephrine directly, because it itself may produce cardiac injury and arrhythmia. You have to then only that's a infusion only we have to start. If a still child is refractory to anaphylaxis, you have to go start IV epinephrine infusion. And if already child is already on beta blockers, you can consider IV glucagon. So important thing is not to administer glucocorticoid routinely. And glucocorticoid may well be beneficial for children and with severe symptoms requiring hospitalization or those with known asthma. And H1, H2 antihistaminics do not relieve upper and as well as lower airway obstruction or shock. So here important thing is in any textbook they tell that EpiPen. So it is not available in India. So what's the current recommendation? You can use 1 ml syringe, whatever using that adrenaline. You can store the doses. We can keep it with room temperature up to 3 months. We can keep it, but we have to protect from the light. So you can use this normal adrenaline as up to 3 months. We can use for the in case of emergency situation. Coming to that case scenario, fifth is foreign body with incomplete obstruction. So another one case scenario is a complete foreign body obstruction. And so in case of incomplete foreign body obstruction, so you have to go for if child is any symptomatic, you have to go for immediate removal. And in case it's a asymptomatic child, but it's not warranted to admit, but stable child, you can go for a plain X-ray radio, plain X-ray chest. If foreign body is opaque, you can detect it. You can go for electively, you can remove the foreign body. Whereas in child is in case of high clinical suspicion, but not able to get in a radiography, you can go for CT, and you can go for virtual bronchoscope image CT. You can look at the foreign body. If it's there, you can remove. Otherwise, we can treat other conditions. And in case of complete obstructions, for no air, movement of air, no sound of cough or progressive cyanosis, and you have to attempt ventilations. If no chest rise, you do Heimlich maneuver, and if less than 1 year, you can do 5 back throws, then 5 chest thrust. If more than 1 year, you can do 5 abdominal thrusts. If unsuccessful, you can go for perform direct laryngoscopy and immediate surgical consultation, and you can go for back and wall mask ventilation, and cricothyroidotomy also you can plan it. Coming to the case scenario 6, it's a case of asthma. You know that nebulized salbutamol, and don't use NS, don't use distilled water while mixing that salbutamol. An important thing. Another one is you can go for if you want to give IV methylprednisolone, current recommendation is not recommending hydrocortisone because it's less potent. Now it is since methylprednisolone is 4 times potent than hydrocortisone, you can continue 1 to 2 milligram of methylprednisolone if you are giving IV, or otherwise you can go for prednisolone, and you can add ipratropium bromide 6 to 8 hourly. And another one is you can go for magnesium sulfate infusion also. But there are many textbooks now, they're telling that IV salbutamol you can give it, but IV salbutamol is not available in India. So oxygenation, steroids, and the maximal inhaled dose of salbutamol are the mainstay of therapy. And so you have to very careful to intubate the child because it may aggravate bronchospasm, and positive pressure ventilation increase the risk of paratrauma. You have to be very careful. If you want to intubate, you can consider ketamine infusion pre-intubation purpose. Next case scenario is pneumonia, and so you have to think of the lobar pneumonia and bronchopneumonia and interstitial pneumonia. If a child is already vaccinated for H influenza as well as pneumococcal vaccines, you have to think of atypical also organisms. You have to think. And in case of atypical, if you are thinking, you can go for chest X-ray showing bilateral perihilar, streaky infiltrate, you can consider azithromycin as an important drug. You can consider, and there are macrolides you can consider. And you can have complications like nematocele as well as empyema and pneumothorax are the important complications you have to think of. And coming to the case scenario is next case scenario is acute bronchiolitis. And in case of important thing in acute bronchiolitis, you have to give heated humidified oxygen. That's very important thing. And so our experience with HFNC is more effective than CPAP. That's we are using more and more of HFNC in our unit. And so what are the drugs in questionable value is nebulized hypertonic saline. It is you have to go with children hospitalized for more than 3 days. In nebulized adrenaline is you can go one dose, but you have to only the action will be very short-lived only. And you can do trial of salbutamol nebulization. You can do one dose. We can give it. If improvement is there, you can continue that nebulization of salbutamol. So otherwise, you can discontinue that salbutamol. So next case scenario is and pneumothorax. I think it's if so symptomatic pneumothorax, you can size is more than 2 centimeters at the level of hilum. You can go for high flow oxygen HFNC. You can do needle aspiration and chest drain. You can give if needle aspiration failed. You can go for chest drain. You can give it. If child is having tension as well as bilateral pneumothorax and hydropneumothorax, all conditions you can plan for chest drain you can consider. So otherwise, if less than 2 centimeters, you can manage with high flow oxygenation, and you can watch for the worsening the conditions, and you can go for anytime you can go for needle aspiration or chest drain. Another case scenario is many times pulmonary edema may mimic like that, and DKA, many times our residents have managed the DKA like hyperactive airway disease also. Sometimes they refer as a foreign body also. So you have to get all the child with any respiratory distress and disproportionately reduced weight within 1 month like that. So you have to ask the polydipsia, polyuria, this you have definitely have to ask. You have to do routine blood sugar level. If you are doing it bedside, you can won't miss that DKA. And so IEM, sometimes if I told already that effortless tachypnea is an unborn error of metabolism may present like effortless tachypnea, and you have to ask the family history of any previous death or any family history of unknown death also. You have to ask ruled out IEM, and you can accordingly you can work out. So take home message is availability of lead consultants, specialty personnel, and as well as postgraduate around the clock is essential for 24/7 quality service in the outpatient as well as intensive care and emergency department. Regular teaching program for the postgraduate as well as staff nurse as well as our consultant also essential to improve our knowledge. So you have to organize the national level CME or workshop, other things at least annually you have to organize. And radiological investigations and intervention has advanced, and you have to, whenever useful, you can use it. It is important to develop pediatric subspecialty like pediatric cardiology, neurology, as well as other specialty also. And in the infection control point of view and antibiotic stewardship, it is necessary to involve efficient microbiology as well as our pediatric department. You have to conduct monthly meeting. You have to look for the auditing also to find out what's the reason for the increasing respiratory infections. And significant changes have occurred over the last 20 years in the infrastructure as well as equipment also. So whenever possible, you have to improve our equipment also. Newer non-invasive modes of oxygen delivery have substantially reduced the need of invasive ventilation both in neonatal as well as pediatric setup. Adequate awareness as well as understanding has to be created among us suburban and as well as rural people regarding the occurrence of these pediatric emergencies. You have to periodically, you have to give either so small pamphlets or you have to educating program also you have to conduct. So the algorithm as well as the protocol approach may reduce the even intern as well as junior PG also they can manage. So you have to use wherever possible, you have to stick the algorithm as well as protocols for the ICU as well as ER and PICU management. Evaluating the child and with each system wise using the assessment triangle like pediatric assessment triangle, pediatric assessment pentagon, definitely it reduce the initial evaluation. Even the senior staff nurse also they can evaluate easily. You can reduce the error of judgment, definitely you can reduce. And the focused clinical observation is the key in the initial recognition of respiratory distress in acutely ill child. Early diagnosis and urgent appropriate treatment will improve the chance of recovery in critical ill child. And diagnosing the underlying etiology is usually possible on clinical grounds. And laboratory investigations are very few and are carried out only after the initial stabilization only. It's not initially you need not go for waste the time to do investigations. You have to clinical judgment is paramount important than anything else. And monitoring and management in PICU, particularly ventilatory support, is again depend upon staff nurse and how that interns getting training. That's a very important thing. And finally, I thank my IAP family and another one is KMCH family and my chairman. And actually, he has recovered completely ECMO therapy. I think the past 20 days he was ECMO. And the one person he has a brand ambassador for our hospital is our chairman was in ECMO post-COVID. Now it's after post-COVID only he's giving that releasing that book. I'm really thankful to our chairman to helping me to come up to this level. And more than that, my IAP family and I thank Ramesh Babu and as well as and all the Dr. Aram Sedil sir, Ismail, and as well as my brother Dr. Tirumurugan Saradi, so helping me to come up this level. I thank my family and my missus is a radiologist. He's working in Quantum Medical College, and my son is first son is completed. Now it's BBS. Now he's currently is a house surgeon at Quantum Medical College, and he's my second son, Nimilan Kirti. I thank all the persons to help me to come this successful life in my career. Thank you very much.
So we move on to the last session of the day. Management of shock in units. I call upon Dr. Chandra Kumar to the stage to speak about management of shock in units.
I now invite Dr. Rajesh Soni, HOD of Rajiv Gandhi Women and Children's Hospital. Sir has done a remarkable work in the field of SAMS program to neutralize pneumonia in Puducherry district. We welcome you, sir, and we would like to introduce the speaker.
We have already promised to all of you that we have to undergo this program, so we have to come. Dr. Chandra Kumar is a member of the NNS, has done his neonatology from teams. He has secured distinction in 11 people. He's an NNS gold medal. He won NNS gold medal for the best paper. He was a senior resident in Jitman and teams, and also assistant professor in man neurology. He also owns remarkable publications, and now he is the senior consultant and HOD of the neonatology child just hospital.
Thank you, sir. Good afternoon, everyone. I thank Tirumurugan sir for this invite. So almost 17 years after leaving Jitmer Pondicherry, I have come for an academic event here back in Pondicherry. So I did my MD in Jitmer from 2002 to 2005, and it is always happy, reminiscent of those memories when I come back, when I cross my institution to reach this order. So without wasting much time, let us go into the topic proper. So in this lecture, we would be discussing the objectives of this lecture would be to look at the common case scenarios with which a neonate would present with shock. So most often we would be coming across with septic shock, but there are so many other reasons where a neonate can present with shock even though there may not be sepsis. So what are the ideal parameters which you can use to assess shock in neonates? how to monitor them, and what are the treatment options which are available to us. So let us start with case scenario 1. So this baby born to a mother at 39 weeks gestation with the 2.9 kg weight. Baby was born by normal vaginal delivery. Of course, it was a prolonged delivery. Did not cry immediately after birth. Baby had to be resuscitated. Baby required positive pressure ventilation and intubation. Apgar score at 1, 5, and 10 minutes were 3, 5, and 7 respectively. And if this baby also had cord blood gas which was available, which showed a pH of 6.84, base excess of -19, and lactate 5 millimole. So this baby was intubated and started on ventilation. Okay. So nowadays, we encourage people to do cord blood gas so that we would know the cord blood gas status, acid-base status at birth, because Apgar alone may not be an important predictor. I mean, may not be a standalone predictor of outcome. So you need to have blood gas which is drawn from umbilical cord blood. So this baby on examination at 1 hour of life is found to be tachycardic. Heart rate is 185 per minute. Respiratory rate of 65 per minute. Blood pressure is around 48 plus 48-30 millimeter of mercury. Peripheral pulses are feeble. Capillary refill is prolonged. But this baby does not seem to have seizures. So obviously from these findings, tachycardia, less BP, feeble peripheral pulses, you would know the diagnosis is shock. But what is the cause for shock? So how will you confirm this? So if you have the privilege of getting echo done, then this baby underwent echo. It was found that ejection fraction was reduced. There was poor LV function, and baby also had pulmonary arterial hypertension with RA-RB dilatation. So the cause predominantly here is asphyxia. Asphyxia has induced myocardial dysfunction, which has led to shock in this baby, and it is not septic shock. So how will we identify this shock? So what are the causes for cardiogenic shock in a neonate? So cardiogenic shock in a neonate can be due to myocardial dysfunction. This myocardial dysfunction can be secondary to asphyxia or systemic inflammatory response syndrome, or it can be following viral infections, myocarditis, or some babies may be born with cardiomyopathy. It could be dilated cardiomyopathy or hypertrophic cardiomyopathy. So the clinical clues to these underlying conditions or the underlying conditions for cardiogenic shock could be asphyxia, ITM, sepsis, postnatal hypoxia. Okay, the important clue which would suggest that the shock is predominantly of cardiogenic origin is your systolic BP will be much less when compared to your diastolic or mean BP. Okay, so when your systolic BP is close to 5th centile or less than 5th centile, but your diastolic is sitting at a comfortable level of 50th or above 50th centile, then always think there could be a cardiogenic cause for shock in the baby. Of course, you need to use echocardiogram to assess the cardiac output, LV function, preferably, in the absence of which you use these clues to identify probably the reason for this shock is cardiogenic. So there, arrhythmias also can present with cardiogenic shock, even though very rare, but supraventricular tachycardia, we have seen a lot of babies presenting with shock, and hyperkalemia can also present with tachyarrhythmia and shock in a newborn. Let us go to the second scenario. So which is nowadays seen as more and more small babies are surviving, less than 1,000 gram babies are surviving. So we have a 27-week baby born at 840 grams birth weight. Mother did not receive any antenatal steroids, and it was a spontaneous preterm labor. Apgar was fairly good for a preterm, 7, 8, and 8 at 1, 3, 1, 5, and 10 minutes. So this baby received CPAP at 5 centimeter water with 30% FiO2. So this baby at again 1 hour of life is found to have tachycardia. BP is on the lower side, prolonged capillary refill time. Baby has cold peripheries. Yes, obviously, based on these findings, this baby is in shock. This baby is in shock. Is it septic shock or is it anything else? So this is what is called as shock of prematurity. When an ELBW baby on day 1 itself, they can develop what is called as shock due to being premature. What is the reason for this shock? It is due to failure of transitional circulation, because They are born early. Once, as soon as the umbilical cord is cut and clamped, systemic vascular resistance rises. But the left ventricle of the baby is not mature enough to handle the systemic vascular resistance. So it cannot pump against the high systemic vascular resistance generated by clamping of the umbilical cord. Hence, it fails. So it is LV dysfunction due to increased afterload. In addition, these babies can have RDS, and thus their pulmonary pressures also may be high, and there may be right ventricular dysfunction as well. So in reality, there may be both the ventricles can be dysfunctional in these babies. So this can be identified by echocardiogram. In the absence of echocardiogram, you have to look into the history and identify whether the systolic BB is more decreased than the diastolic or mean BB, and you have to take a decision about what kind of management you would do for this shock. So all shock in neonate, even in an extreme preterm, is not septic. So this is the message from this scenario. So let us discuss what are the points which would suggest that it could be distributive shock. So distributive shock can be vasoconstrictive or vasodilatation. So the vasodilatation form of distributive shock happens in sepsis. It could be due to drugs or neurogenic, which is very unusual in a newborn. So vasodilatory form of distributive shock happens in septic shock. The vasoconstriction form of distributive shock is the one which is peculiar for this ELBW infants. So systemic vascular resistance increases, there is peripheral vasoconstriction, but myocardium fails and is not able to pump against the high systemic vascular resistance, which is peculiar to ELBW infants. Let us come to case scenario 3. So this baby born at 37 plus 4 weeks gestation with a birth weight of 2.9 kg, normal delivery, born at an outside hospital. You do not know whether baby received appropriate antenatal care, mother received, no significant antenatal risk factors. Baby cried well after birth, but baby presents to you on 3rd day of life with massive lower GI bleed. So when you examine this baby is paper pale, feeble pulses, baby has acidotic breathing, baby is tachypneic. So if you do gas, it is shows severe metabolic acidosis, and you get ultrasound abdomen also done if you have the facility, and SMA SFB axis is normal. Why this has to be done is any lower GI bleed, you have to always rule out malrotation and volvulus. Okay, so what could be the cause? So if you do further investigation, this baby is anemic, platelet count is normal, but PT and APTT are prolonged. So this could be vitamin K deficiency bleeding, which could have resulted in hypovolemic shock in this newborn. Okay, so again, all bleeding baby need not be DIC, need not be sepsis. It can be just pure vitamin K deficiency bleeding. Okay, so the classic form of vitamin K deficiency bleeding presents with GI bleed. Okay, so this baby was managed with fluid bolus, vitamin K, PRBC transfusion, and then these babies usually do well. I mean, rapidly the APTT improves, and then most of these babies, if there is no intracranial bleed, they do not even require FFP transfusion. So what is hypovolemic shock? So what are the causes for that, and what are the clues to diagnosing hypovolemic shock in a neonate? So hypovolemic shock can be due to blood loss. So blood loss can be feto-maternal hemorrhage. Okay, so a baby can be born at birth very pale in shock. It can be due to chronic feto-maternal hemorrhage or acute feto-maternal hemorrhage, which happened just prior to delivery. So it can, the bleeding need not happen after birth. It can happen antenatally or intrapartum as well. So it can be due to IVH, it can be due to pulmonary hemorrhage or DIC. In these cases, the blood loss will be evident to you. It can be due to plasma loss, due to low oncotic pressure, or due to capillary leak, or it can be due to ECF loss due to insensible water loss or polyuria, which is very commonly seen in ELBW babies because of their poor immature kidney and skin. Okay, so these are all the explanations for clues which you will be looking for hypovolemic shock in a baby. So plasma loss can happen in necrotizing enterocolitis because whole gut is inflamed. There is a lot of third spacing, fluid accumulates within the gut as well as outside the gut, so there will be hypovolemic shock.
So pure hypovolemic shock is extremely rare in neonates. So you have to be very careful in identifying this as hypovolemic shock and going ahead with multiple boluses. Okay. Let us come to the scenario 4. So this baby born at 38 weeks gestation, 3.5 kg, born by LSCS, baby was doing very well, breastfed, baby was in ward. At 28 hours, this baby was found to have off color, ashen gray pallor and cold peripheries. So this baby was shifted to NICU. So this baby had poor, tachypnea, baby had tachycardia, the pulses in the lower limbs were weak. So BP in the lower limb was less when compared to upper limb. There was a murmur and there was a hepatomegaly. Okay, so this babies, whenever you find that lower limb pulses are weak, you have to almost always rule out duct dependent systemic circulation. So such babies also we do see commonly. So especially interrupted aortic arch and coarctation of aorta, which presents like with shock in a term baby. Okay, so here also you need to remember that it need not be always septic shock. So this baby, you can consider giving one fluid bolus, but what is more important is giving an inotrope, which will increase myocardial contractility and keeping that ductus open by giving prostaglandin infusion. Okay. So let us come to one more scenario, which probably those who do more and more of core neonatology would come across. So preterm baby, 31 weeker, 1.2 kg, baby has a long line, which can be either umbilical venous catheter or PICC line. Okay, so this baby is on room air, develops sudden pallor and poor capillary refill time. Central pulses are weak, peripheral pulses are weak. Baby progressively goes in for hypoxia and bradycardia. So this baby had to be intubated, and this is a real scenario which happened in the unit. So this baby was found to have pericardial effusion because of long line, which was put in the baby, which can be either UVC or PICC, because the right atrium is very thin. It can, these tip of these UV catheters or PICC line can pierce and then cause pericardial effusion, which can cause tamponade and present like this in a preterm baby. Okay, so this type of shock is also called as obstructive shock. Okay, it is not only obstruction of vessels, which is due to aortic stenosis or coarctation of aorta, even tension pneumothorax or cardiac tamponade can cause obstructive shock in a preterm. Okay, in a baby newborn. Okay, let us come to the next scenario. Again, this scenario you will see commonly. Term babies on breastfeed. Okay, so around 8 hours old, baby was found to be drowsy, cold, with prolonged capillary refill, features of shock. So this baby was treated with fluids, inotropes. Okay, so then later you realize that this baby also has some abnormal genitalia. So these babies, they present very late. Okay, so this baby presented at day 7 of life. So it may not be in the immediate newborn period, but they present towards the later first week or second week of life. So when these babies present, again, you may not think that all babies with shock have sepsis. You have to look for other causes also. So this baby typically genitalia is abnormal. If it was a male baby, you will not find this is a virilized female baby. If it is an under virilized male or sometimes male baby normally virilized, but they present with features of shock, and you may find that sodium is low and potassium is high in these babies. They may be having hypoglycemia, and you have to treat these babies as congenital adrenal hyperplasia. So in addition to CAH, you have to always think when there is a postnatal collapse, CHD or IEM. So let us come to the last scenario, which is the most common one, which we will always think when a baby newborn presents with shock. So a baby born to a mother at 38 weeks gestation, there is history of PROM 20 hours. There is history of maternal UTI in the 2 weeks prior to delivery, but baby was asymptomatic at birth. Abgas were good, normal transition, but baby developed lethargy at 48 hours of life, and baby was shifted to NICU. When you examine this baby, periphery still remains warm. There is flash fill, capillary refill, but baby is tachycardic and tachypneic, pulses are bounding, and BP normal for gestational age. Mother is not sure when baby passed urine. So this baby, when subjected to investigations, revealed high CRP, low total count with a normal platelet count. So this could be probably a septic shock. Okay, so septic shock can present to you, especially in inborn babies in a compensated phase where BP can be normal, Pulses can in fact be bounding, but you should not miss this baby, because these babies, when you leave them untreated, may go on to decompensated phase of shock. So this is the distributive, that is vasodilatory form of distributive shock, which you will commonly see in sepsis. In addition to the history of lethargy, the baby can have sclerema, there can be bleeding due to DIC, and often BP will be normal with a wide pulse pressure in these babies. Okay. So these are all the common scenarios in neonate which can present with shock. So it is not only sepsis, there are so many other reasons for shock in a neonate. So let us come to the definition of what shock is. So it is an acute complex state of circulatory dysfunction resulting in insufficient oxygen and nutrient delivery to meet tissue requirements. Okay, so shock is like in circulatory dysfunction wherein you will not be able to meet oxygen and nutrient delivery to other tissues. Okay, so it is not only fall in blood pressure. Okay, so what are the determinants of hemodynamic status? So blood pressure, all of us know, it is determined by cardiac output and systemic vascular resistance. Cardiac output in turn depends on heart rate and stroke volume. So any changes in the heart rate like dysrhythmias can affect cardiac output. On the other hand, stroke volume will be affected by preload, afterload, and then contractility of the myocardium. So systemic vascular resistance is regulated by a lot of neuroendocrine factors, which can cause vasoconstriction or vasodilation, thereby altering the systemic vascular resistance. Okay. So we have already seen this table. Just it is a recap. Okay. So let us come to assessment of shock. Traditionally, what we do is, do we have a pointer? I just use okay, sir. So traditionally, we always, whenever we say as baby in shock, we will always look for BP. Okay, so that's why BP is put in the center middle. Okay, but it is not only BP. Okay, so BP may not fall in most of the shock. So when BP falls, it is already, baby is already in late phase of shock. Okay, so in addition to BP, you have to also look into heart rate, whether there is tachycardia disproportionate to the gestation of the baby. You have to look at capillary refill time. You have to look at urine output. You also, if you have facility to do a blood gas and look at lactate, you also look at the lactate. So heart rate will be disproportionately high for the gestation. Capillary refill time, anything more than 3 seconds is abnormal. If it is more than 4 seconds, it has high specificity for identifying shock. Urine output, if it is less than 1 ml per kg per hour, then it indicates that probably something is wrong with the perfusion. In addition to these classical parameters, which is used day in and day out, you can also look at other parameters like central peripheral temperature difference. You put a probe here or the auxiliary thermometer you can use and measure, and then peripheral temperature you measure, and if the temperature is more than 2 degrees Celsius, it is very much indicative of shock. If you have facility to measure CVPs, yes, you can do. In some scenarios, you can just look at hepatomegaly, new onset crepitations, which is very difficult in a newborn baby. And if we have facility for blood gas, then always please look at pH, base excess, lactate. All these things would give you a clue to diagnosis of shock. Why we say is BP is not the only indicator which will tell that baby has shock is because, so there may be scenarios where BP may be low, but at the same time when systemic vascular resistance is also low, perfusion will be normal. Okay, so BP may actually be low, but because systemic vascular resistance is also low, tissue perfusion is not affected. By definition, what we said, if the cardiac output or output is not able to meet the tissue oxygen and nutrient requirement only, then we will call it as shock. Okay, so here, even though BP is low, because systemic vascular resistance is low, there is normal perfusion. There is no tissue hypoxia. So on the other hand, you may have a scenario where BP is quite high, systemic vascular resistance is also very high, and hence perfusion is not happening to the tissues. So this happens when you overuse inotropes, especially with adrenaline, high doses. So you will be seeing normal BP, but lactates will be sky high. Okay, you will not be able to feel any pulses. Peripheries will be very poor. Okay, so this is a condition where you will chase the numbers and achieve normal BP numbers, but in fact perfusion will not be there. Effective perfusion will not be there. So BP is not the sole measure of determining whether shock is there or not. You have to depend on lot of parameters. So there are problems with each and every parameter. So I can't depend only on color of the baby because it is very subjective. Someone looking pink to me may not be pink to the others. So CRT again may be delayed in other causes. Just simple hypothermia without shock, then the CRT may be prolonged. Core peripheral temperature should be, as I told, should be normally less than 2 degrees Celsius. So it may be influenced by vasoactive drugs, peripheral temperature, ambient temperature. Heart rate can increase in other reasons, especially caffeine we use in preterm babies. That itself can cause tachycardia. BP is a late sign, and urine output is again a late marker. And most of the time, mothers may not be aware, or we may not be monitoring well in NICU unless the nurses are strictly instructed to do so. Okay, so no one reliable sign. You have to have a combination of signs which is more informative for identifying shock. So in this table, you can see that individual parameters have very poor sensitivity for identifying shock. You can see that none of the parameters, even blood pressure less than 30 has only sensitivity of 60% in identifying shock. Okay, so no single parameter is predictive of shock. You have to use your clinical judgment in the background of the history to identify whether this baby is having shock or not. So mainstay of treatment, let us come to the treatment part. Okay, that is what is about diagnosis of shock. Okay, it is still gray. You have to look into the history. You have to see the antenatal details. You have to see the presentation of the baby. You have to look into the signs and symptoms and some lab parameters to come to the conclusion that this baby is in shock. So fluid resuscitation is the mainstay of treatment. You have to treat them with fluids. Unlike pediatric cases, you start with 10 ml per kilo bolus. You give it over a period of 1 hour, not 20 minutes. So you have to reassess the baby whether this baby would need repeated boluses or not. So nowadays, to assess the status of intravascular fluid status, we also use what is called as, we put the ultrasound probe and look at the IVC status, and we also measure IVC collapsibility index and see whether the fluid status of the baby is adequate or not before going for the next fluid bolus. So we have to be careful in giving too many fluid boluses in preterms, because PDA is a problem in preterms. IVH, too many boluses, and rapid boluses can cause intraventricular hemorrhage. And we need to remember that hypovolemia is not a cause of hypotension. It's not a common cause of hypotension in newborn. Okay, so when it comes to fluid choice, crystalloids are good enough. You don't have to use colloids. Okay, so you have to also correct associated hypoglycemia and hypocalcemia. Let us come to the choice of vasoactive drugs. So before going to vasoactive drugs, you need to know what is the function of these receptors. So alpha-1 receptor increases the contractility of the heart. Alpha-2 receptor stimulation causes peripheral vasoconstriction. Beta-1 increases the rate, conduction as well as contractility. Beta-2 causes peripheral vasodilation. Alpha-2 vasoconstriction, Beta-2 vasodilatation. So DOPA-specific receptors causes renal and mesenteric vasodilatation. So these are the commonly used inotropes. You can see that dobutamine predominantly increases the rate, contractility and conduction in the myocardium. Okay. On the other hand, epinephrine acts on all the 4 receptors. So it increases the myocardial contractility. Also, it causes intense peripheral vasoconstriction, and it can cause excessive tachycardia. When compared to epinephrine, norepinephrine will not cause much of tachycardia, but at the same time will help in improving the myocardial contractility and increases the peripheral vasoconstriction. Okay. So what we need to remember is in very small babies, these receptors are not very mature. So the alpha-2 activity may be more predominant than alpha-1. So when you use high dose adrenaline in these babies, peripheral vasoconstriction may be more intense than alpha-1 activity. So myocardial contractility may not be stimulated that much, but vasoconstriction will be very severe. So in fact, you may aggravate LV dysfunction if you use high doses of adrenaline in extreme preterm neonates. So I think for want of time, let me not dwell into the details of these inotropes. All of you know the dose ranges and then the targets where they act. So what I would do would like to say is that dopamine is the commonly used inotrope. Next is dobutamine. Dobutamine increases myocardial contractility, and to a lesser extent, it has an effect on heart rate, but does not cause decrease in systemic vascular resistance. So when we use dobutamine is the scenario where I told, in a preterm baby where systemic vascular resistance is high and there is myocardial dysfunction, because dobutamine preferentially increases the cardiac contractility, and then take care may sometimes reduce systemic vascular resistance to some extent. Dobutamine is preferred in this scenario. So epinephrine we use when shock is not responding to dopamine. We start at a low dose of 0.1 to 0.3 microgram per kg per minute, and you should use caution in premature infants, as I detailed earlier. So dopamine versus epinephrine both are comparable, and there is a lot of evidence for that. Norepinephrine we use nowadays more often in septic shock, especially when they come in the phase of distributive shock. The advantage here is it causes good amount of vasoconstriction, but it does not cause too much of tachycardia, unlike epinephrine. So in combination with the dobutamine, norepinephrine works well when there is a combination of distributive as well as bit of myocardial dysfunction in babies. So milrinone especially we use when we suspect persistent pulmonary hypertension in newborns. Again, here the caution is that it causes significant hypotension. So you have to handle blood pressure by using other inotropes. Vasopressin, one of the rarely used agents. Again, it is commonly used in septic shock. It causes only peripheral vasoconstriction and does not have any impact on myocardium. So the problem here is because of its antidiuretic hormone effect, it causes too much of fluid retention and it can cause hyponatremia also. So hydrocortisone, okay, it plays a very important role in management of shock in neonates. So it has genomic and non-genomic effects. What predominantly it does is, because premature babies have very few number of adrenergic receptors, when you use hydrocortisone, they help in improving the number of the receptors. And then when the drug binds to the receptor, the response to the drug also is improved when you use hydrocortisone. So hydrocortisone we commonly use when we are on already 2 inotropes in a neonate. So when you are on dobutamine and adrenaline or dopamine adrenaline, then we add hydrocortisone so that the permissive effect of hydrocortisone comes into play. So dose is 1 milligram per kg per dose 8th hourly. For up to 5 days, you may have to use. So let us not go into the details, but what are the endpoints of treatment of shock? So normal heart rate, capillary refill time should be less than 2 seconds, and BP should be within normal limits. Baby should be having normal perfusion, and preductal, postductal saturation difference, if it is there, should be less than 5, and baby should be passing adequate urine. Should have adequate urine output. Okay, so these are all our endpoints. So take home message is that shock is a common presentation in a neonate. Early identification is the key to avoid morbidity and mortality. No single parameter is diagnostic. You have to use a conglomeration of findings, interpret the clinical pictures with a picture background history. Then only you will be able to identify the exact cause of the cause. Then only you can treat the shock appropriately. You have to judicially use inotropes, and use of bedside echo, the perfusion index from pulse oximeter, all these things are helpful in managing shock appropriately in newborns. Thank you. Yes, sir, it does happen. Flash pulmonary edema, it happens, especially when we get late referred preterms with RDS.
when they come late in the first day of life, when you give surfactant, immediately the pulmonary vascular pressure drops, and then they have, flooding of blood into the pulmonary circulation, and then they develop sometimes with the pulmonary.
Nice presentation with more of the practical tips. Any further questions?
If there's no further questions, I request our chairperson, Dr. Rakesh Soni, to facilitate our speaker, Dr. Chandra. I now request our Secretary of IIT Positive Chapter, Dr. Dawson, to participate our chairperson, Dr. Rakesh Soni. I just request Dr. Shanmugam sir to participate our I now request Dr. Shanmugam sir to participate our Joint Secretary of IIT Positive Chapter, Dr. Ethan. With this, we conclude this today's session. We thank everyone for your patient listening. I now request everyone to stand up for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जगति तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you.
Thanks, man.
இன்னொன்னு இதுல க்ரீஸ் பண்றாங்க. க்ரீஸ் பண்ணாரு. இது இல்ல இந்த இமேஜ். லீவ் கொடுத்துருங்க.